Does that make sense, Mr. Hewitt?
It does, Mr. Chairman, yeah.
Okay. Thank you very much. I apologize again for not giving you the opportunity right upon completion there, but obviously if you have anything that comes up, please reach out, and we look forward to working with you on those pieces of legislation. Committee, just a reminder, and in part why I thought it was okay for us to expedite this afternoon a little bit. These reports that we are to hear from and about are located on the website, so they are posted. And if any of our constituents reach out, please remind them that they can take a look at these hospital documents posted online. So with that said, anything for the good of the cause before we get started this afternoon? Okay, I think let's proceed then. Jill, I believe that that Franz hopefully is waiting in the wings for us from the Department of Health.
Yes, I will go ahead and admit him.
Okay, thank you. Mr. Fuchs, if you are there, we're not seeing you yet.
Mr. Chairman, this is Franz Fuchs, the Department of Health. Were you asking about me?
Mr. Fuchs, absolutely. And
I apologize.
Nope.
I was on, my audio was having some troubles and I couldn't hear. I just saw you were waiting for somebody to answer. So
no problem. Thank you for being here this afternoon and stepping up your schedule so that you can do so. Mr. Fuchs, you're here obviously with the Wyoming Department of Health, and our topic is hospital facilities this afternoon, and take it away. We'd love to hear from you.
thanks, Mr. Chairman. Good afternoon, members of the committee. Mr. Chairman, my name is Franz Fuchs, policy analyst with the Department of Health. And Mr. Chairman, I know the topic is really sort of an overview of Wyoming hospitals, kind of the structure, the count, the beds, that kind of thing. If that's kind of what you're looking for this committee, I can do a more abbreviated version of the brief I'd prepared. The brief I prepared is an overview of the entire report, and I'm going to share my screen if that's okay. This brief is a little more in depth than just kind of going over the nuts and bolts of the hospital system. So what your pleasure, I can do either way. I can do the full brief, or I can sort of abbreviate it and get it just to the kind of points you want to hit.
So, Mr. Fuchs, we've had the opportunity, we've had these documents, and you know, maybe a medium. I think that we probably don't have to drill down into every corner, but certainly I think we're here this afternoon to have an understanding of our hospital network, because that's going to help us to maybe make some decisions going forward. So hope that makes sense. I don't know if you really need to go into every little detail. How about that?
Yes, sir, Mr. Chairman. And I will, these slides, they extract essentially images from this report, which is the other document you have. And I think my goal really today is to kind of give you a roadmap to this report. So when you guys are having discussions, you may know kind of where to look to find the information going forward. That's hopefully my goal for today, but I can certainly reference page numbers if you like. There's a lot of statistical information here that may be helpful in your discussions or not, given that a lot of things have changed since we did this report. But without further ado, I'm happy to start with this presentation.
Thank you, Mr. Fuchs. And committee, you do have this, I believe, certainly on your computers, but you may have it hard copy. I know I received a hard copy of this, but please proceed, Mr. Fuchs.
Thank you, sir.
I apologize, Mr. Fuchs, but committee, once again, I'm not able to see all of you. So if you'd like to jump in with a question, please don't hesitate. Thank you.
Okay, thank you, Mr. Chairman, members of the committee. So the report we did last year was really focused on these two primary research questions that were specified in the legislation, and really looking at access to specific hospital capabilities, specifically time-sensitive capabilities. So for things like trauma and childbirth, where you really can't wait for care, how does that look across the state? And the second question was really kind of there's a tension, a fundamental tension in healthcare, and I think in most sectors of the economy between cost and access. How do you really balance sort of an efficient distribution of resources against really highest quality and broadest range of medical services, right? These are not necessarily the same thing, and there's definitely a tension between the two that really has to be negotiated. There was also an applied research question. We know kind of why the study was originally proposed, and that was sort of looking at the potential for new hospitals in 3 places around the state: Riverton, Pinedale, and Saratoga. So Riverton currently has sort of I guess a shell of a hospital in some ways. It used to be a hospital, a county hospital. It was privatized at some point, and then eventually consolidated with the ownership in Lander. I think in the around 2014 or so, they sort of started reporting as one hospital, with the Lander campus being the main facility. And I know my understanding is they sort of gradually moved resources away from Riverton to Lander. So we've been kind of looking at this issue, looking at a separate new hospital in Riverton. Pinedale, as you all know, has clinics that are very close to being capable of being a hospital, but Sublette County sort of been in discussions over the past years on whether or not they want to go for the critical access hospital capital construction and designation by Medicare. And then Saratoga, of course, doesn't have a hospital yet. They would be that was another area that we were asked to look at. So with that, this slide deck, pretty much we have an executive summary of our findings. We go through the background of what we found for the current hospital system in Wyoming, which is probably what is of most interest to your committee this afternoon. And then we have sort of these maps of time-sensitive conditions for childbirth and trauma specifically. So in the executive summary, just starting that out, we were looking at sort of evaluating the economic and medical viability of hospital services. And our 2 major findings are, one, that most hospitals in Wyoming seemed economically viable. Now that's based on the data at the time. Obviously the COVID-19 epidemic may have changed things, and I'm sure Eric Boley from the Hospital Association will bring you up to speed on what that means for hospitals today. But I do want to caution that all the data in the report is the latest currency is really 2018 is kind of when those cost reports are filed. So it is a few years old. But at that time, we did think that the hospitals were economically viable, most of them.
So Mr.
other,
Fuchs,
yes, sir.
Let me just interrupt for a moment. On that front, I remember about 3 years ago that Senator Peterson and myself worked on a budget amendment, which was to specifically help our critical access hospitals out across the state, because at that time there seemed to be some pretty big concerns about the viability. So how would you define economically viable? Their cash on hand wasn't very good 4 or 5 years ago, I know, but can you expound a little bit there?
Yes, Mr. Chairman, we sort of looked at a collection of indicators to define economically viable. I would say that when we say most hospitals, there's definitely hospitals that aren't in very good shape, and it definitely is sort of a patch. There's a patchwork, of good hospitals and ones that may be in more precarious situation. But I'll show you some of those indicators later on in this deck, and hopefully that will kind of explain kind of what I mean by which indicators we chose and kind of what hospitals look like. But the metric that we used was essentially comparing them against their peers. Now we tried to define their peers nationally by looking at bed size, patient count ranges, whether they're a critical access hospital or not, whether they're rural or not. And we tried to use the distribution of hospital finances nationally as sort of a benchmark and see what percentile they fell into. And you'll see that in some of the next slides.
Okay, thank you for that. Appreciate it.
Yes, sir. The other major point we looked at was physician and provider availability. We think this is from the purposes of medical viability. This is one of the main limiting factors, and it's no secret to anybody here that Wyoming, ranks relatively low nationally when it comes to the amount of doctors we have per capita. But we do want to point out also that there's really significant variation across counties. It's not just a universal phenomenon. You'll see certain counties have extremely high proportions of doctors per capita, even higher than some of the, if they're considered states, they'd be higher than New York and Massachusetts. Other counties are way at the bottom. So the distribution between counties, we think, is also significant, not just the overall average. And then as far as access to care for time-sensitive conditions, the other major deliverable in this report, we assessed that Riverton and Pinedale really did seem to have worse access when you look at those two indicators of time-sensitive conditions, childbirth and trauma. Saratoga was less high on that needs list, if you will. As far as recommendations, the report did ask us for our recommendation. We are kind of in the pessimistic health economist camp on this, and we don't have really a very positive message here. There's a balance here between access and cost. So when you add a new hospital or expand your services, you certainly get more access, but that adds cost because there's a lot of fixed costs that go into that maintaining that hospital. And if you're poaching clients or inpatient admits from other hospitals, you're going to have less people to spread that fixed cost on, right? So you can't just grow hospital service demand, generally speaking, unless it's outpatient knee replacements or something shoppable. So there's a key point here that really you're going to pay for that access you want. And that this is really a fundamental trade-off. And I think in any economic sector, when you're talking about contracting, for example, there's that iron triangle. You can have it good, you can have it fast, or you can have it cheap. Pick two of those. And so we think this is kind of the same trade-off that we see in healthcare. If, again, a big if, I bolded it here, the legislature believes there is a role for the state in negotiating this because there may well not be a role. We would suggest as the department considering time-sensitive services differently from shoppable services and pay for them differently. That's kind of our, how we would negotiate it. Again, there's a lot of good arguments why the state shouldn't be involved in this business at all. But when it does come to access, there are certain services where emergent care really matters. ER rooms, for example, with stroke, you really need access to imaging, whether it's a CT or MRI scanner very quickly to be able to diagnose that. With childbirth, obviously very difficult childbirth, you need access to a higher end hospital, or at least be able to transport to that hospital. Whereas shoppable services like a knee replacement, people may have time to kind of consider the costs, consider the benefits, shop around, look at what's going to cost them, what the quality is, and really make a decision based on sort of a free market more principle. So those are kind of how we sort of recommended separating those, just at least separating your thinking out for now. Obviously, this if is a big if.
So Mr. Fuchs, periodically, I'm going to just stop you real quickly to make sure there aren't any questions thus far. Committee, anybody want to jump in? Okay, thank you. Mr. Fuchs, please continue.
Yes, sir. So that moves us into the background section. And just as far as numbers go, we have 33 hospitals in the state. 30 of those accept Medicare, Medicaid patients. So the others are like physician-owned hospitals, which may not be enrolled with Medicare, Medicaid, Medicare for legal reasons, and so they aren't going to take those patients. So you really have, of that 33, you have 27 that are sort of the general acute care hospitals. When you think of a hospital, that's kind of what you're thinking about. That excludes WBI, which is a psych hospital, or Elkhorn Rehab, which is a rehab hospital, Aspen Mountain, which is a physician-owned hospital. So this 27 number is kind of your top line. Of those, Medicare and by extension the whole healthcare system, you really subdivide that group into two groups. One is the prospective payment system hospitals, or PPS hospitals, and these are your bigger hospitals that are paid prospectively, as the title would suggest. So Medicare will pay the hospital a fixed amount essentially for a certain admission. It's not cost based. They won't just say, oh, you spent 20 days in the hospital, we're going to reimburse you for those 20 days. They say, no, we're going to pay you $5,000 or whatever the amount is. And it's determined by a formula. So that's the main distinction between them. And then, of course, the other 16, which are critical access hospitals. And from the perspective of Medicare, the critical access hospital designation is really important because that enables them to essentially do the cost-based reimbursement. So they get to say, hey, it cost us X dollars to treat these patients, and Medicare will reimburse, generally speaking, almost all of that. I think it's between 99 and 101% of that cost. So it's a pretty good deal for those critical access hospitals from a Medicare perspective. The governance and ownership and for-profit status of those hospitals vary. Now we do have a table on the study, and I've switched here on my screen here. Table 2 will kind of show you which hospitals the list of hospitals in Wyoming, the community they're in, what type they are. So prospective payment system is PPS. And then you have your list of critical access hospitals down at the bottom. We have the governance structure, whether it's a hospital district, whether it's a county memorial, whether it's a for-profit, the management company, as we knew when we did the study in 2019, and then the number of beds, both acute and long-term care beds for that hospital. So table 2 is kind of your go-to reference if you're just thinking about beds and ownership. We also have a map, and I'll go back to my slide deck because I think I have it on the next slide. So here's a bigger shot of that map. You can kind of see the hospitals in and around the state. I've scaled the PPS hospitals are red circles, and they're scaled. The size is basically proportionate to their beds. And then the little red with the cross is the critical access hospitals around the state. So you can see we've made some editorial decisions here. For example, Riverton, we don't really believe that's much of a hospital anymore. So you don't see a dot where Riverton is. It's really Sage West Lander is kind of the main dot there. And I think the community in Riverton, you may hear from public comment, but I think they would agree with that assessment. And then I'll switch back again. I hate to keep switching back between the report and the slide deck, but I do want to point out table 3 shows kind of some of the volume. So it's similar to table 2. It has a list of all the hospitals and where they are, whether they're a PPS or a critical access hospital. But this shows, roughly speaking, the volume in terms of outpatient visits and inpatient admits that they had, as well as our estimate for inpatient days and an average daily census for how many days they might have been in the hospital. The final DRG cost weight column here, this is essentially a measure of intensity of how many resources are going into each admit. So greener means there's more resources. This is a more capable hospital that spends more, has more capabilities. There's more resources getting poured into each admit. These are more complicated cases, whereas red numbers tend to be lower acuity, more, in the trauma world, you'd, stabilize and ship. So you're gonna take somebody, you're just gonna stabilize them and move them to a higher end hospital. So that the redder have, these are just kind of indication of the capability of the hospital, as we see by this very crude indicator, which is how Medicare, their overall sort of proportion of admits as measured by that. I know this is kind of a complex subject, but I just kind of want to point you. So when you do read the report, table 2 and table 3 are kind of going to be your go-to for your summary statistics. And Mr. Chairman, it looks like you might have a question, but I can proceed if you like.
Thank you. Go ahead. I can't see the whole screen, so please, committee members, whoever, please jump in. Okay.
Mr. Chairman, I think he thought it was you that had the question.
Okay. Thank you, Mr. Fuchs. Please continue.
Yes, sir. Okay, so moving on to slide 8. Now, with that background, we're moving into sort of the economic viability. We chose 10 metrics to quantify economic viability, and we broke those into 5 categories. So we have measures of liquidity, profitability, cost structure, and then we look at public payers, so Medicare and Medicaid and uncompensated care. Now you'll note that all the data in these assessments come from the Medicare the HCRIS, or Healthcare Cost Report Information System. These are essentially cost reports that the hospitals submit to Medicare for reimbursement. The data quality here really can be variable depending on, there's certain worksheets, for example, that hospitals get paid based on the results of those worksheets. And so those tend to be fairly accurate because they can be audited. The statistical worksheets where no one really will look at them and they don't determine the payment, they can be less reliable. But generally speaking, this is the only source of data that we really have for hospitals that's consistent and really has sort of a national scope. So we really can get access on every hospital that's registered with Medicare for most fiscal years since 2010. And basically they are about a year or two delayed. So, that's kind of the currency of the data we're talking about. And just starting out with liquidity, what we did here, and there's again another eye chart, and I apologize for that. And this starts to get into the next section of the report. But we have each hospital listed here on the y-axis, if you will. But think of it more as a table. And then we have the fiscal years on the bottom. And we have 2 indicators. So one is the quick ratio and one is the debt to capital ratio. And I'd have to refresh my memory on exactly what went into these formulas. It's been a minute since we did these calculations. But the quick ratio is similar to sort of a current ratio. as far as being able to, your ratio of current assets to current liabilities, and debt to capital kind of shows more the overall how much the hospital may be leveraged as far as very longer term liabilities in its asset and balance sheet. So you can see what we did we have the actual values for example, the quick ratio of Wyoming Medical Center as calculated from these cost reports in 2012 was 2.4, meaning they have approximately twice as many current assets as current liabilities in that sense. And what we did was we took the quick ratio for every hospital in a peer group. We tried to estimate what the peer group for Wyoming Medical Center would be based on the bed ranges, based on its rural, urban nature, whether it's a teaching hospital. And we tried to look at that nationally and say, okay, well, let's rank them all in order, and let's take the percentile. Where does Wyoming Medical Center, where does that 2.4 fall into on that distribution? And generally speaking, white on this table means it's close to the median or the 50th percentile, and green means it's further up on the distribution, and red means it's further down on the distribution. And while we don't mean to apply any judgment on this, generally speaking, a lower quick ratio is considered less healthy than a higher one. Although there are points where you can have way too much cash sitting around and not being invested, which would also be bad. So basically, the stoplight colors kind of indicate, from our perspective, which hospitals are more healthy than others. And you can see impressionistically, there are certain hospitals like Weston County that had sort of a dip, and I think they've reformed their management structure, or they had some changes that were made in their leadership, and they've kind of maybe pulled back a little bit from the brink from 2016, 2017, when their quick ratio went down quite a bit. But there are certain hospitals, there's that patchwork. Some hospitals really do seem to have consistently worse financial health than others. Platte County would be another example, and these mostly tend to be on the eastern side of the state. So you can see Carbon County is another one. Campbell County, again, I wouldn't say this is they're actually probably managing very lean here. They probably are fairly healthy, but I think just looking impressionistically at the entire scope of all these hospitals, there's a lot more green than there is red. So that's kind of not a great, it's hard to get one number to say whether or not they're healthy or not, but hopefully this kind of provides you a little more detail on at least from a liquidity perspective, which hospitals may have more trouble meeting their current obligations than others.
Mr. Chairman, may I ask a question?
Go ahead, Representative.
Thank you, Mr. Chairman. So the comment about the hospitals on the eastern side, is that any idea or speculation can you elaborate on why necessarily on the eastern side versus the rest?
Mr. Chairman, Representative Duncan, we couldn't say why. Just observing that if you look at, say, Crook County, Weston County, and Platte County, those then, compared to hospitals in the basin or hospitals in the center of the state, there's that was the only pattern that we really observed. Now, as to why, I certainly can't speculate.
Mr. Chairman, follow up.
Go ahead.
Thank you, Mr. Chairman. Those are, because Goshen is mine there in Torrington, and it's almost solid red. Could that have anything to do with having bigger hospitals next to those near the state line?
Mr. Chairman, Representative Duncan, there are flows out of state, and it really does vary by county, and we do have some material in the report on that. I think in particular, Crook and Weston counties do have really abnormally high flows out of state, and I think it is because of the proximity, to other outside bigger hospitals. But there are hospitals big hospitals in Utah and in Billings where you might see the same effect for hospitals in the basin, for example. There's a lot of referrals to Billings, and obviously Evanston, Sweetwater County would be referring a lot of people to Utah, and then Laramie, Cheyenne. We do have a larger hospital here, but a lot of people do go to the Front Range. So it's not necessarily universal to that part of the state, but it's certainly maybe the relative size of those hospitals compared to the out-of-state ones may be a factor. But again, I don't want to speculate without a lot more data.
Thank you.
Okay. Thank you, Mr. Fuchs. If there aren't any other questions, please continue.
Mr. Chairman.
Senator Scott.
Mr. Chairman, just further in response to Representative Duncan's question, one of the things you have to consider is a number of these small hospitals they're receiving tax support. Their hospital district or a county memorial that potentially can get some tax support. And some of the ones on the eastern side are in areas where there isn't much mineral in the tax base, and the tax base is pretty poor. And that may be impacting some of the ratios here, both as far as the debt and particularly the quick ratio. So you may have a non-business factor that is affecting some of those things. Somebody a little more familiar with some of the individual hospitals could perhaps fill you in, but that is another factor to consider here.
Appreciate that, Senator. Thank you. Committee, any other questions? Okay, Mr. Fuchs, please continue. And I believe, by the way, that we will have Eric Boley with us, and he may have been admitted into the meeting already, but he may have some answers as we go along to committee.
Mr. Chairman.
Representative Furphy.
Yes, thank you. Let me ask about the debt to capital ratio. So those in the red or pink, are they at risk for failing? Do I understand that correctly?
Mr. Fuchs?
Mr. Chairman, Representative Furphy, no, I wouldn't say they're at risk for failing. I think all this is a relative comparison to their peers. They may be at higher risk of default if this is a major factor in defaults or whatever, but it doesn't necessarily, the number itself and the color does not mean to imply that they're going to be in imminent risk of failure. It's really just relative to their national peers.
Thank you.
Okay. Thank you.
Mr. Chairman.
Senator Scott.
Mr. Chairman, a further comment on that, and when he's done, I do want to say a few words, but in that particular question, the quick ratio is probably more important if you're looking at risk of failure. And if you had a quick ratio that was consistently below 1 and significantly below 1 for an extended period of time, then you start to really get worried. That's more where you're going to see the crisis show up. Where you see the patchwork that we're seeing here, they seem to get in trouble, and then the management gets cured, or whatever was going wrong gets over with, and they revive themselves. And I'm very much agreeing with the conclusions that Mr. Fuchs has reached here, but that's probably more important than your debt to capital ratio.
Okay, thank you, Senator. Mr. Fuchs, please continue. Mr. Fuchs, did you happen to mute? Because
Mr. Chairman, I apologize. It was on mute. Yeah.
Thank you.
Just wanted to say, Senator Scott and Eric Boley will certainly be able to correct me on my facts here and the interpretation here. I would like the data to speak for itself. I'm not a hospital expert, so I'm happy to present the data, but I'm glad to hear Senator Scott, and I know Eric Boley will certainly have some interpretations of this as well. But I'll proceed with our next indicator here, which is profitability. We chose two indicators here. One is total margin, which essentially looking at all the streams of income and all the sources of cost. So that percent of profit, if you will, although for a nonprofit, it's less meaningful. And then specifically with patient services margin, that's excluding investment income, excluding concessions, and excluding all those cost centers as well. So this really just looks at the patient services. And again, I mean, that might be tax support might explain why certain hospitals could run a consistent loss year after year after year and still survive. But again, here, we do want to point out the color coding. There's a lot of hospitals that do tend to doing pretty well. Those tend to be more of the for-profit. If you look at, for example, Sage West and Evanston Regional are for-profit, as well as Torrington. Those tend to have higher margins than the nonprofits, and that could just be a design the nonprofits aren't in the business of making money generally. When they do see excess revenue, they have to plow it back into, cost or give it back, I suppose.
Mr.
Any questions on the profitability?
Yeah, just real quickly, Mr. Fuchs. I noticed Sage West Riverton, and I guess this does date back to 2018. And it was shortly after you obtained this information that Riverton closed, was it not? And just trying to get my time frame right. That's pretty green, and that hospital closed anyway.
Mr. Chairman, this is actually sort of an artifact of the data. The Lander campus and the Riverton campus merged. So the results back in 2013, so the results from 2014 onward are reported for both hospitals. And we can't disentangle which one was Riverton and which one was Lander. So to say that the Riverton hospital is doing well I'm not sure we can say that just based on these numbers here, because this represents the combined entire both campuses.
Okay, thank you for that clarification. Appreciate it.
Mr. Chairman, this is Eric Boley. I don't think you can see me, but I could add some clarity to this if that.
Sure. Mr. Boley, jump in there, but then I'll let, the plan is to kind of let Mr. Fuchs go through the data, but by all means, Mr. Boley, welcome this afternoon. Appreciate it.
Thanks, Chairman. I just a couple of quick comments. Sage West Riverton is not closed, and I think that's a misperception. They still have 24/7 ER services. They do ER services. They do OR. They have lab. They're still functioning as a hospital, so they are not closed. They're still Medicare certified. And so what Mr. Fuchs is indicated is when they did combine their two campuses under one management agreement, I think that's where the change was. Going back to Representative Duncan's question on some of those ratios, especially when you take a look at the Banner facilities, I think the real reason that you see the numbers that you do is because Banner does a lot of their bookkeeping and a lot of their administrative services out of their corporate offices in Phoenix. And so they don't keep a lot of cash on hand. It all goes through a central repository. And so that would change your ratios. And I think you'd see that with some of the others. Sage West might be another example of that, Evanston Regional, because of the way that they're owned and operated. It's going to change some of those ratios. And with that, I'll be quiet, but I just thought I might add a little clarity.
No, I really appreciate that, Mr. Boley, and we do want to get to you and have you available for questions. But that's very helpful to help us walk through this a little bit. And we'll just allow Mr. Fuchs a little bit of interruption along the way from the committee, but also for Mr. Boley to add or subtract. So Senator Scott, you had a question.
Yes, Mr. Chairman, but I think I better hold it till later till we hear from Eric.
Okay, thank you. Mr. Fuchs, please continue.
Yes, sir. And I'm certainly happy to. I know Eric Boley has a vast amount of expertise. I'm happy to be corrected anytime. I don't need to wait until the end. Certainly, if he has something important.
I appreciated knowing that I had a misperception with regard to Riverton too. So thanks for that, Eric. And please continue, Mr. Fuchs.
Yes, sir. So again, the next indicator we looked at was cost structure. So we and again, these indicators, I think Mr. Boley's brings up an interesting point or a good point with respect to the data that is reported. There's all kinds of ways that hospitals can report this data. Whether they have the larger mothership of hospital corporation that controls the books, that data may be reported elsewhere. So I do want to emphasize the data we do have can be spotty. And so, really what we look at is the overall impression, right? Impressionistically, is it more red or is it more, green? Because the actual data points themselves, I think you could find very good reasons why a specific data point may be an outlier. But just to continue, we looked at cost structure, basically looking at two aspects of that. One is depreciation, what percent of their reported assets are depreciated, which is kind of an indication of the age of the facility. So certain hospitals are older than others, and you can see when they reinvest, for example, Washakie Medical Center, their depreciation goes from 80 to 42. So there was obviously some large capital investments made at that point in time. I know Hot Springs County recently is building, doing a lot of construction, and that would probably drop in the future. But this kind of gives you a sense of which hospitals are older than others. And then the cost per average daily census, we were essentially trying to find a measure that would represent, how efficient is the hospital on an output basis. And this is a very imperfect measure. And I'm sure Mr. Bowley would be happy to take a knife to this particular indicator. We were trying to find something that would measure, a rough measure of efficiency or, resources per bed. And this could be because they offer, a lot of very intense, very high-end services. It could be that they're, maybe have too many staff. It just depends on some of these higher numbers, what the actual reason is. So I'm not sure this particular right pane is particularly useful, but it does kind of show which hospitals maybe have a lot of resources per bed or per daily census, and which hospitals have less. So for example, Niobrara, I think, is an example. Niobrara community is more of a nursing home, I think, than a hospital. So I think we deleted, they were so low on some of this cost structure, we deleted them because they were basically outliers in the data, for example. So again, I would encourage you to take all this data with sort of a grain of salt, because it does come with its own caveats.
Okay, thank you.
Moving on to,
Please continue. Well,
yes, sir. So
Mr. Bowley, please jump in.
Mr. Chairman, just to clarify, Niobrara is not a nursing home. It's a critical access hospital, a small one, but they own and are operated as a hospital. They don't have a nursing home at all. But their numbers would be low because of the amount of services they provide that community.
Okay, thank you. Committee, anything else before we proceed? Okay, Mr. Fuchs, please continue.
Yes, sir. So moving on to public payer mix. So we looked at the percent Medicare or Medicaid as far as the payer mix. This is kind of an indication of how much they depend on public payers versus private. In this case, green is lower. So green generally relying on public payers, not the I guess best business strategy for a lot of people. Relying on Medicaid, a lot of hospitals have to do that. A lot of hospitals have to rely on Medicare or Medicaid, but generally speaking, a hospital that has a lot of private insured would have a healthier bottom line than those without. So we chose to sort of invert the scale here. Green means a lower reliance on Medicare, Medicaid, and red means a higher reliance. And so you can kind of see the hospitals, how they fall out there. And then as far as cost coverage, we look at what percent of, how does Medicare revenue compare with revenue with their Medicare costs. And again, these are, the 101s, there's a consistent pattern. These are the critical access hospitals. That's pretty standard for a critical access hospital to be reimbursed at that level. But you do see that for the PPS hospitals, there is relatively low cost coverage for their Medicare patients. And that could be, and we'll get to that in a couple slides. Their costs may be too high, or the revenue may be too low. That would be the two explanations for why that ratio would be low. But we'll get to that in a slide or two. I just want to pause for any questions on this slide.
Mr. Bowley, any thoughts? You want to jump in there?
Mr. Chairman, I think the one thing that needs to be realized, and Mr. Fuchs is doing a great job here. We've been through this quite a few times together, but the reality is that the critical access hospitals do not receive anywhere close to 101% of their cost coverage. They receive 99% of their cost coverage based on allowable costs, and the allowable costs compared to actual costs is significant. And so it's difficult. Medicare is one of the most layered and complex payers I've ever seen. But what I would say is I wouldn't even be able to tell you these are valid numbers. It may be based off of their allowable costs, but and that's only for Medicare patients. It has nothing to do with all the other patients that the hospitals are seeing. This doesn't take into account uncompensated care, charity care, bad debt, a lot of other things. So I would just add that into the conversation.
Thank you for that. Mr. Fuchs, please continue.
Yes, sir. And just to respond to Mr. Bowley, that's absolutely correct. These are based on allowable costs just for Medicare patients. So, for an example would be when a hospital has offices, they build offices to recruit physicians. Those would not be considered allowable costs. The gift shop is not an allowable cost. The flower shop is not an allowable cost. I think the offices for physicians is probably the biggest component of those non-allowable costs. But he's absolutely correct. These are just the allowable costs for only Medicare patients, and all those other factors don't come into play. We do have a slide, however, on later on sort of the uncompensated care and Medicaid. I do have a brief digression here, if that's okay, with respect to Medicare, however, and that's Chairman Scott on joint labor and Chairman Wilson asked us separately how to look at the actual Medicare payment rates. So how do how does Medicare pay Wyoming hospitals compared to others? And so we used we took the top 10, what are called diagnosis related groups, or DRGs. These are sort of bundles of services that are provided by a hospital for a consistent set of symptoms. So for example, a heart failure with major clinical complications would be DRG 291, and that would incorporate all the services that are incorporated into that particular problem, right? And so we took the top 10 by volume and we compared it by hospital referral regions. So these are the hospital referral regions. You can see the only one in Wyoming is the Casper Hospital Referral Region. The rest of the hospitals fall into these other out-of-state HRRs. And the reason we did that is just to kind of group it again by sort of peer groups and kind of regionally. You want to kind of compare Evanston, for example, with Salt Lake versus Evanston with Wyoming Medical Center, for example. But we show them all here, and again, another eye chart for you, and this is hopefully more readable on paper. But what we do is we take the Wyoming hospitals in these hospital referral regions, and those are below this red line. So you can see all the Wyoming hospitals here. These are the prospective payment system hospitals. These don't include any of the critical access hospitals because they are paid on a cost basis or almost cost basis, not a prospective amount. So these amounts here are the prospective payments. And you can see, so for example, Evanston for this DRG would be paid on average $10,600. Ivanson would be paid $12,600 for that DRG. And what we do is we, again, the same methodology, we take all the hospitals in that area and we sort of rank them and we color them according to that rank. And I think what's the conclusion that we see here is that generally speaking, Wyoming hospitals do, with the exception of Wyoming Medical Center here. And the reason I think I can talk to you, and Eric can certainly talk to you in a minute, but with the exception of them, generally speaking, Wyoming hospitals do receive more for these DRGs than their counterparts in their respective, their out-of-state counterparts in their hospital referral regions. Now, the reason we think Wyoming Medical Center is down here is this data may have been reported when they still had lost their sole community hospital status. So there are certain nuances in Medicare, as Mr. Bowley refers to, noted, and one of those is this designation called a sole community hospital. When Mountain View sprung up in Casper, that went away for Wyoming Medical Center. So they lost a significant bump on their DRG, their reimbursement rates. And this, what the data may reflect that. However, they have since acquired Mountain View and they have, I think, regained it. And Eric can correct me if I'm wrong on that particular case. But with that, I'll pause for questions or corrections before I move on to the Medicaid and uncompensated care.
Senator Scott.
Mr. Chairman, this is a good place to point something out here. We analyzed this data further, and before going further, let me say I really would like to compliment Franz on the work he's done. It's considerably higher quality than we often get from our expensive hired gun consultants. Excellent job here. We found something very interesting with this. Talked to Chairman Wilson and I talked to particularly Cheyenne, the regional medical center there, the Cheyenne Hospital. And one of the things that came out of that is that high fixed costs is a reality right across a lot of medicine. In these DRGs, having 50% or more of your costs be fixed costs is not unusual. And the fixed costs include not only the capital costs that we think of, but often include some of the expenses that are personnel and spend. You hire specialized personnel to operate some equipment, and that turns into a fixed cost, and the amount of volume you've got to recover your costs is absolutely key, because the more the volume, the more cases you have to spread your fixed costs over. And there's an example here that is striking. Look at on DRG 470, which I believe is the joint replacement one. Look at Cheyenne's competitor, Poudre Valley. They're getting from Medicare $15,200 a case, whereas the Cheyenne Regional Medical Center was getting, I'm looking at the right column, yeah, at $20,100 per case. So they're getting more per case, but Poudre Valley has almost 1,000 cases, 994 a year, whereas Cheyenne was, let me get the right column here, getting 125 cases. When you chase the math through, Poudre Valley is getting less per case than Cheyenne, but because of the volume, that is very profitable for Poudre Valley. Cheyenne's getting paid more per case, but it is unprofitable for Cheyenne because their volume isn't anywhere near as what Fort Collins is, and Fort Collins is taking business away from them. And that goes, it's counterintuitive to you actually push the numbers and see what the effect of those fixed costs is. But that's a problem right through our whole system. Even Casper and Cheyenne do not have the volume to compete with the large hospitals on the Front Range, in Salt Lake, in Billings, places like that. And so they can lose money with a Medicare reimbursement that is actually on a per case basis better than elsewhere. So that's one thing that we have to remember all through this, that volume is a major driver in how well the hospital does. It's independent of the hospital's efficiency or anything, it's what's their volume. The other thing we found was when we looked at it, the Medicare reimbursement system does not appear to be rational. It is all over the place. It'd be hard to prove it was discriminating against Wyoming, but it's paying a much smaller percentage of our costs because our volumes are so low. Even though the payments per case may be higher here, because of the low volume and high fixed cost, we're still in trouble dealing with Medicare. It's an interesting situation. One thing that does jump out at us, and we'll get into it later if we talk about the Fremont County situation, you're having the sole community provider status makes a tremendous difference, 30-40% or more in your Medicare reimbursement. And so that's very critical. If you have another hospital within, 40 or 45 miles, Eric? I forget which. You can't be a sole community provider. That's another general hospital. A specialized one like say a psychiatric hospital doesn't count. And so that is a major determinant, because Medicare, the previous chart was a little misleading because it was going on what was being paid. When you look at it in terms of where the costs are, what real book of business is, Medicare is just under half for most of these hospitals. So it's 16, 17% of our total population. But us old geezers can get things wrong with us. And so we're a higher percentage of the hospital's book of business. And what Medicare pays is absolutely critical. So those are a couple of factors you really got to consider when you look at all this data.
Okay, thank you, Senator Scott. Mr. Fuchs, I'm going to let you continue.
Yes, sir. And I think those are excellent points. And I think Senator Scott points to the kind of what the fundamental underpinning of this study is really that cost versus access. When you increase access by building additional hospitals, that volume becomes a problem because those are really largely fixed costs. Even the personnel, you're not necessarily going to fire a bunch of nurses based on volume changes. And I think the pandemic has really sharpened that distinction quite clearly. When the volume drops, a lot of hospitals, I mean, that really makes it or breaks it. So continuing on to the final slide for the viability or economic viability, we look at Medicaid and uncompensated care. Medicaid cost coverage. Again, there's another tricky issue, and I'm sure Eric and I can debate this for a while. But what's an allowable cost? This is essentially a parallel measure to what Medicare considers the Medicaid, how much Medicaid reimburses. This includes I believe it includes the measure of the upper payment limit. So this includes the side payments that we make, and that whole scheme would take a while to explain, but essentially what happens is the hospitals will provide the state match, and then we draw down additional federal match and pay it all back to the hospitals. So I believe these cost coverage figures incorporate the upper payment limit amounts. But you can see there, it is relatively red across the board. A few spots of green here and there, but Medicaid cost coverage is certainly low. Same thing with uncompensated care. A lot of hospitals are giving a lot of uncompensated care, especially relative to their peers. So there are some green spots where the uncompensated care is relatively low, but certainly community hospitals like Wyoming Medical Center at the top, you can see are devoting a substantial fractions of their operating cost that doesn't get to bad debt to folks that just can't pay for it. Any questions on this slide? Okay.
Senator Scott wants to weigh in on this one.
Mr. Chairman, question this time. Your uncompensated care, that is a percentage. What's the percentage there? What's it a percentage of?
Mr. Chairman, Senator Scott, that's a percentage of cost, total cost. I know it's been reported as percent of charges in the past, but that's not the case here. This is definitely a cost basis.
Mr. Chairman.
Go ahead, Senator Scott.
Mr. Chairman, and that's done properly. The thing you have to look at is then what's the volume? Is this a uncompensated care? Is that a percentage of the cost that's recovered from those people? So you're getting 8% recovery, or is it 8% of your total cost is uncompensated? I'm still a little confused by this chart.
Mr. Fuchs?
Mr. Chairman, Senator Scott, that's 8% of the total cost is uncompensated.
Okay.
Mr. Chairman.
Mr. Boley, go ahead.
I'm sorry, just a quick thing as we start talking about hospitals, I think one of the important things to look at is I don't know how many other businesses would be happy to receive 72% of their cost coverage. And so if you take a look at Wyoming Medical Center, we've come up with what Franz identified as schemes, but what we've tried to do is maximize our reimbursement from Medicare and Medicaid. But even by assessing provider assessments upon ourselves and being able to draw down additional federal funds on a Medicaid basis, we're still only receiving 74% of what it costs us to deliver that care. There are a few that are in the green, but with our governmental payers, we're never even really recovering what it actually costs us to deliver that care. And it gets into a huge debate, but it needs to be realized that if 40 or 50% of your book of business or even more is a governmental payer, it makes it pretty difficult for you to stay solvent and viable.
Mr. Boley, I appreciate that. And before I go to Senator Scott again, I just want to say that you and I have been working the last couple of years together on several issues that drive this uncompensated care number in the hospital in the center part of the state. Some of that is due to Title 25 concerns, and Chairman Nethercott and her group have been working on that again, and it's just something we're going to have to stay on. But the fact is, this is a hospital here that inherits a lot of uncompensated care, some of which comes from elsewhere, but it's a very real thing. Senator Scott has always cautioned that, sure, you can, numbers, you can massage numbers, but I trust that this chart of Mr. Fuchs is probably pretty darn close. There's a lot of that impact to our hospitals. Senator Scott.
Mr. Chairman, 2 points on this. On the uncompensated care, that has to, you have to make enough money to keep the doors open and pay your bills. So that has to be cost shifted to the other payers. And half your payer is Medicare, and they won't accept that as a cost. So means all that uncompensated care gets shifted to the private costs, which drives them up and makes it more difficult for us to compete with the out-of-state people like on the Front Range. So that's an important feature there. Probably if you look at the cost Medicare doesn't allow, the biggest one is picking up a share of the uncompensated cost, because they don't allow any of that in their allowable costs. The second point I would make is the legislature needs to look very carefully at this Medicaid cost coverage chart. Eric was right. Even at 74%, you're only making 3/4 of what it's costing you to provide the care. Now, Medicaid is between 8 and at most 15% of the book of business of any hospital. So it's not overwhelming, but we're in trouble. If the hospitals were depending on Medicaid, we'd bankrupt them all. So as we consider how we're going to balance our budget, you cut into Medicaid, you've got a bunch of providers that are very dependent on Medicaid, where if you paid this, you'd bankrupt them all and we wouldn't get the service. So the cost cuts are likely to fall heavily on the hospitals and the doctors, and you're going to really start hurting people. So that's a caution as we go forward trying to balance our budgets. Remember this slide, we're already hurting them a lot.
Well, Senator Scott, good points. And so many things we could spend all afternoon on, but the additional thought in that regard is that you begin to cut benefits, which is very likely, cut insurance. What that's going to do is drive a lot of cost over into the Medicaid camp, and there go your costs as well. So that's a caution on all of the insurance front. As businesses and government cut back on what they're paying on insurance, that's the private market that helps to float the hospital. So anyway, Mr. Fuchs, I want to get back to you and help you through this report.
Yes, sir, Mr. Chairman. And if anytime you tell me to speed up, I'm happy to start going faster. I can cover the medical provider density. This was looking at sort of medical viability. We interpreted this as sort of looking at the availability of your labor inputs. Intuitively, we all know that we're pretty low, right, in terms of access to doctors or nurses or nurse practitioners, so on. Mental health providers. We tried to quantify this. This is looking at just a very crude measure of MDs per 1,000 people. This omits a lot of healthcare practitioners, but the nice thing about this metric is it's been tracked consistently since the 60s. So it's kind of a way to get in time. And you can see Wyoming as a state is the red line, the US average is the black line, and then all the 50 states are the gray lines there. So you can kind of see the spread. So there was a tighter distribution back in the 60s, and that's gotten haves and have nots in some cases. And you'll see that on the county basis. It's even worse inside the state. So that's the Wyoming compared to the US average. I think we're just above I believe it might be Idaho is the one below us, but we're pretty damn close. When you look at it by county, however, you can see, again, this indicator tracks since 1960, the same kind of trend where certain counties have more MDs per capita than New York or Massachusetts, but other counties are less lucky. And I think some of the overlooked counties we have are really Bighorn and Niobrara. The basin does seem to suffer a shortage of now again, this is just MDs. There are plenty of other allied healthcare providers out there that we have to look at as well. But you do see this trend of certain counties do seem to be, average. Certain counties are well above average, and then you do have counties that are really hurting. So even within Wyoming, there's a big distribution, and that's a really important point to make.
Okay.
We can also look at other types of providers. So beyond MDs, we include the other type of doctors, the DOs, as well as advanced practice nurses, nurse practitioners, physicians assistants that are in patient care. And by this metric, again, treating kind of counties like they were states, you can see certain counties, the bigger counties, the very scenic county in the west, tend to be average or above average, whereas certain other counties, again, Bighorn County, a really big deficit, right? 0.9. That's bottom. That's very, very low on the national scale. And same thing looking at specialists. The picture is very similar. So when we're looking at, our recommendation is when we're looking at state policy, it might be prudent to consider these county differences instead of sort of a statewide program. If you're just recruiting a bunch more doctors to Jackson, I mean, no offense to Teton County, but you're not necessarily ameliorating the problems that we see on the distribution here.
Okay, thank you for that. Mr. Boley, anything to add to that topic?
No, Mr. Chairman.
Okay, thank you. Please continue, Mr. Fuchs.
Yes, sir. And so then we looked at other healthcare providers. So for example, this is again just sort of a nice to know map. This is EMS service areas, quote unquote service areas. So we look at EMS agencies and their kind of response area, and we try to model that and show that graphically. I'm not sure what conclusions you can really draw from this map, but it's just there for your information. And with that, that's kind of what that's the overall summary of the medical service sector. And I can pause before we get into the access side on the time-sensitive conditions if there's any questions.
Any questions, committee? Otherwise, we're going to keep moving through the report and get to Mr. Boley and other things. So, Mr. Fuchs, thank you. This is good stuff. Please keep going.
Sure. So moving on, just talking about access to care, we considered trauma and childbirth here. These are a subset of the time-sensitive conditions. I'm not going to read you the slides, but these are pretty intuitive of why they might be time-sensitive. When you look at the risk of childbirth by county, this is kind of just another interesting slide for me. You can see the fertility rate, total fertility rate per 1,000 women is sort of the y-axis. The age groups are on the x-axis, and each county is its own little graph, right? And I just found it kind of interesting that counties like Crook County actually have a very high fertility rate compared to counties like Laramie County or Albany County in particular. I think because there's so many college students in UW that probably driving that rate down. But just a fun graph there, I guess, for information's sake. But this is kind of what we use to model the childbirth risks across the state. For an uncomplicated delivery, again, a kind of another eye chart. We tried to map based on that, the expected number of births coming out of these counties, what would the closest hospital would be. I believe there's a mistake here. I think this should be, say, Lander here. It shouldn't say Riverton. I believe that's where we model that hospital. But otherwise, you can kind of see these would be like the first level for an uncomplicated delivery, how far you'd have to go depending on where you live to the closest hospital that's capable of handling that. So you can see some of them out of state, like if you're in Bags, you're probably better off driving to Craig versus going to Rollins. But now this is just uncomplicated deliveries. When you look at more like a semi-complicated delivery, now there's only other bigger hospitals that can handle that. So for example, now if you're in Bags, you're driving to Steamboat or getting airlifted to Steamboat. If you're in Riverton, you're probably going to Wyoming Medical Center. But there are certainly hospitals within the state that are capable of handling semi-complicated births. And then we get into the very, very complicated, high-end NICU type births, and generally speaking, there are no hospitals in the state that generally you will be airlifted out of state or driven out of state. Those would be the hospitals you're going to based on where you happen to live. So when you look at access, when you calculate those travel times by these, we looked at county subdivisions. There were certain county subdivisions that really had a very, very long sort of the number of bursts that were outside 30 minutes and the number of bursts outside 60 minutes. Those are kind of the measures that we use for access. And so here you can see, at the top of the list, Wind River Reservation, county subdivision of Fremont County, Bridger Valley, Pinedale, and Afton. And then, of course, on the 60 minutes, Pinedale, Newcastle, and the Wind River Reservation are on the top there. So Sublette County, again, these are substantiating kind of the reasons why we said that Riverton area and Sublette County in particular have relatively low access to time-sensitive care. Moving on to trauma. Trauma risk, unlike childbirth, is heavily concentrated over 65. So once and this is mostly due to falls, which are considered trauma. So you can see that young men tend to have a higher rate of trauma due to stupidity, most likely on the early young ages, but then the risk increases pretty exponentially with age after age 60. So this is how we modeled trauma across the state. Again, just a fun informational graph there for a very depressing topic. And then we have the closest trauma hospital. This is a level 4. So this is the lowest possible level of trauma designation in the state. You can see those regions there where you'd have to drive. One interesting anomaly here was Wheatland. You can see the Wheatland Hospital isn't even a level 4. So if you're in Wheatland, you're going to Douglas or Cheyenne or Scottsbluff. Same thing with Torrington for this particular level of care. Those are kind of interesting points to make. And then, of course, when we looked at that, Torrington, Wheatland, Pinedale, Lander, these are sort of the highest levels that we noted. The number of traumas, expected traumas that were occurring outside 30 minutes and 60 minutes, respectively. So again, not a comprehensive listing of all the county subdivisions, but the top, I believe, 25.
Okay, thank you, Mr. Fuchs. Just a quick pause. Any questions from the committee? Mr. Boley, anything you want to add to this couple of topics? Okay, Mr. Fuchs, keep going. Appreciate it.
Yes, sir. So I'll just gloss over this real quick. We built a pretty complex model for trying to model if you put a new hospital somewhere, what would the expected number of admits be? And that there's a lot of factors that go into that. I won't gloss over it here, but basically we started with a population model of the state, which is looking at sort of census block level of population. So these are kind of color coded by population density. And we started from there and generated, synthetic admits. There's a certain risk of inpatient admission based on your age and sex. For Sublette County and Teton County, we had to model this because Sublette County doesn't have a hospital, and Teton County, I think St. John's wasn't necessarily in that data. But nonetheless, we built a certain amount of admits, and then we did sort of this hospital choice model, and we came up with, okay, if you put a hospital in Riverton, here's our expected number of people of inpatient admits that you'd see in a year. And there's a range there. There's a sort of a uncertainty interval. It's a pretty wide one. I'm not sure that's a very helpful number to those people that are planning for a hospital there. But I think Fremont County was seeing an expected about 2,500 to 3,000 annual inpatient admits a year. If there were a new hospital in Riverton, Sage West would lose approximately 750, and Riverton would gain approximately 750. Is our model. Again, this is a model. There's a lot of things that it's subject to the assumptions you make. We assumed these would be relatively small hospitals starting up. You wouldn't just build a massive hospital to start out. We assumed. So because it's a smaller hospital, it's going to have less capability and attract less volume. But that said, we also looked at the payer mix. So we looked at kind of the percent of admits that would be by age. So the statewide average is sort of this black dot with the uncertainty, and then the Riverton, Pinedale, and Saratoga would all be expected to have older than average admissions, as well as a higher dependence on Medicare than the statewide average. So those are just cautionary notes for those folks that may be trying to plan a hospital. The critical access hospital designation, I think, would be a friend because it's a much better deal for Medicare. If you're going to have a lot of Medicare admits, that's probably the business model you want to follow versus trying to compete on the PPS level. And with that, sir, I'm happy to wrap up and turn it over to anyone else who wants to talk or take any questions.
Well, Mr. Fuchs, thank you. That all of that information is interesting and valuable. As we take a look at this, of course, committee was a topic that we were asked to look into by our management council, which spread all of these topics out through the various committees. And so this is subdivision kind of work, political subdivision. So it rests here as well as with labor and health. But anyway, well done, Mr. Fuchs. Committee, any questions of Franz before we let him take a pause? Okay, Senator Scott.
Mr. Chairman, questions for Franz. Looking at the last couple of slides and the what are the criteria for getting a critical access designation? And it may also be a question for Mr. Boley. If you had a separate hospital created in Riverton, would it be feasible for them and Lander to get critical access, or would the proximity and the history prevent both of them from being designated critical access if the size was right? And second, am I right in thinking that right now the feds regard Lander and Riverton as essentially the same hospital, just 2 units of the same hospital, and their sole community provider? And if you had separate hospitals in Lander and Riverton, am I right in understanding they would lose that status and lose somewhere in the vicinity of 30 to 40% of their Medicare reimbursement on a per case basis?
Mr. Boley, that really sounded like a question for you. So how about if you take a shot at it first?
All right, I'll jump in here, Mr. Chairman. So the hospitals are too close together to qualify for critical access designation. One of them would have to be 25 beds or less. I do believe that there is one stipulation within the critical access designation rules that if the facility in Riverton were built on the reservation or on land that's owned by the Native American tribes, that they might qualify for critical access. But neither of them are right now. They have way too many beds and are run as a PPS hospital. I don't know if that answers your question, Chairman Scott or Senator Scott, or not.
Mr. Chairman?
Now go ahead, Senator.
Mr. Chairman, am I right in thinking that if the feds are now perceiving them as one hospital and regarding them as a sole community provider, am I right in thinking that if they split and were separately owned and managed, that they would be considered separate hospitals and they would both lose that sole community provider designation, with a consequent sharp fall in their Medicare reimbursement?
Mr. Boley.
Well, Mr. Chairman, the one thing that I would say is that if a new hospital is built in Riverton, it would automatically disqualify that new facility and also the Sage West facility from being sole community providers. I would actually have to talk to my CEO with Sage West to find out, and I can probably get you an answer before we're done with the call here, whether or not they do have sole community provider statuses attached to the combination of the two, or if they're both freestanding.
Thank you for that. And Mr. Boley, we certainly have you down as someone for the opportunity for you to make a presentation to us. We can continue some questions regarding the hospital viability study, or we could committee allow Mr. Boley to make some comments and then follow some questions at that point. I'm inclined to do that because he may touch on some things that we would ask him anyway at this point. But real quickly, anybody want to follow on that line of questioning? Okay, so Mr. Boley, please jump in this afternoon and give us what you can on hospital facilities and hospital network out there. We're anxious to hear from you.
Thank you, Mr. Chairman, and I'll try to just provide some history, some background, some updates on what's going on around the state, and then make myself available for questions. And as you know, all the charts that Franz created, and Mr. Fuchs is one of the smartest guys I've ever met. He does a fantastic job in his position, and we're lucky to have him in our state. But everything that he has created for you is prior to COVID, and COVID's really changed the game. I don't know how long we're going to be dealing with that, but it's a different landscape than it was just a few months ago. And so I'll try and address pre-COVID, but then I think there are really some serious considerations need to be made as we take a look at COVID. And we've learned some really important lessons during the last 3 or 4 months. They've literally been hell for my folks. And I thank my lucky stars I'm not a hospital CEO anymore. I don't envy the position that they've been in. But I think the charts that Franz shared with us are pretty telling. And I think the thing to realize is that hospitals in our state, they do a great job, but they're under tremendous strain and pressure. And it's a very, very difficult business. And as we look around the state, as we look at that map that was created and look at where the hospitals are situated, there's a different story to be told for each community. And one size does not fit all. There are definitely some great benefits to critical access designation as far as our reimbursement is concerned for those facilities. One of the things that really we lack in our state, and as I looked at that chart on the DRGs, I think one of the things that Senator, sorry, I'm so used to calling Senator Scott, Chairman Scott, because we've worked together for so many years, but one of the things that he pointed out is the reimbursement that goes on in states around us. And as I looked at the list of those facilities, they all belong to large systems. As you look at Utah, IHC, University of Utah, and then you've got Mountain Star down there. So they have 3 huge systems, which actually creates efficiencies, helps to drive down costs, and it definitely increases volumes. And it's the same in surrounding parts of our state. So as you look at South Dakota, it's the same thing. As you look at Colorado, it's the same thing. We really don't have systems in our state. We have a bunch of freestanding, standalone facilities, except for a few. And you know, we've focused pretty heavily on one of those, and that's the Sage West facilities that they belong to a large corporation, and they have a lot of resources that they can bring to bear that can help create efficiencies and can help in those situations. But our small critical access hospitals, most of them really struggle. We have 2 or 3 in the state that do based on location, based on community buy-in, and based on population. We've got several that are doing phenomenal, but they still struggle. It's still difficult for them. And then we've got our smaller ones. And as we talk about Crook County, as we talk about Newcastle, you know, they've created a model up there that works for them. But as we look at services that are lacking or services that have been decided not to be delivered, there are no OB, there are no deliveries done in those 2 communities. They don't do any surgeries. Those are all normally referred somewhere else. We have other facilities in our state that don't do OB. And so that exacerbates, creates those gaps or those areas that we don't have the coverage that in a lot of other states you would find. But those are business models. And then we have other critical access hospitals in our communities that the communities have basically demanded and told them what they want to do. And that is probably the biggest tipping point when it comes to healthcare. There are really smart business decisions that can be made when we look at running our hospitals in the state. And then there are decisions that are made to provide services that it's the only way those services are going to be delivered in those communities. And it's usually through the hospitals, and it's usually done at a loss. There are very few services that our hospitals do anymore that actually generate revenue or income. The rest of them are loss leaders. And so I think the thing that we've learned from COVID is before COVID hit, we had hospitals that were on the brink. We had some of them that literally had less than a week's days cash on hand, which is a very alarming thing. That means that if they ran into a problem, they have enough cash on hand to cover about a week's worth of expenses, which include payroll and all the other expenses. it's untenable. And that's with tax revenue. When COVID hit, we saw decreases in our revenues 60, 70%. And so we started March 13th. Hospitals in our state did the right thing and they quit doing, and I don't want to make this all about COVID, but I think this adds to our conversation. So they voluntarily did the right thing. They quit doing elective procedures in an attempt to preserve PPE. And really the only places that hospitals make money is through diagnostic testing, through elective procedures, through surgery. Our clinics in the state saw 40 or 50% patients. And so we were in an absolute free fall. Hospitals that were on the brink were over the brink in a matter of days. And without the CARES funding that came in, and it took a while, but I was convinced that we were going to lose at least a handful of our smaller hospitals in the state. And that, I guess that's the thing that the point I'm trying to drive home here is we consider new facilities, or as we even consider the existing facilities, it's that tenuous and it's that's that close to the line. And then as we take a look at the economy and the fact that we're going to see shrinking tax revenues, and a lot of our small hospitals or hospital districts and rely on their mill levies to keep them at a 1 or 2% margin. And this is back when we actually had tax revenue. As we see those shrinking tax revenues, and then as we face some really uncertain times, and as we hear from the Department of Health that they've been instructed to start looking at areas to cut, there's only so much that the system can withstand before the system collapses. And so I think that's a really important thing to consider as we talk about this. The other thing that Senator Scott did a really good job of, and as you can tell, we've been in the trenches on this for a long time discussing this, but the cost study that was done last year, it was pretty telling. It's nothing that we didn't already know, but it was good to have it validated. But he did a really good job of talking about the fact that running a hospital has huge fixed costs. And if you don't have volume to offset that fixed costs, your procedures and everything you do are going to cost more money just to cover the cost of doing that. And when you don't have revenue coming in, those fixed costs can absolutely eat you alive. And half of it's usually just employment alone. It's difficult to recruit and retain specialists in healthcare without paying them a very competitive wage. The other thing that I think Franz did a great job of pointing out is that for the most part, our state is pretty short or sparse when it comes to coverage from our medical profession. It's difficult to recruit and retain doctors into a lot of our communities, and with the downturn in the economy and with a lot of the other things that are going on, it's even going to be harder. We used to have programs that were in place that could help us with that, loan repayment programs to help offset the tremendous debt that doctors and other providers come out of college and medical school with, but that has been defunded. So we really don't have anything that we can use to entice and bring them in except high wages. And by paying 90th percentile of the average wages, we're increasing the cost, but we're actually able to at least bring providers in. But that also drives up the cost of healthcare in our state. The cost-based reimbursement is an interesting concept, and I think we've touched on that briefly. But when I was in Kemmer at the hospital there, I was there for 20 years, and we went through the conversion from a PPS hospital to a critical access hospital. We were one of the last to do that. I think Rollins was the final one that would qualify as a critical access hospital and actually made that jump. But while I was there, I started working with the folks in Pinedale, and they've been looking at what to do in Pinedale for 7 or 8 years, I think. They've gone through 6, 7, 8 different feasibility studies. But when things were good for them and there was a lot of taxes flowing in, they had 2 state-of-the-art clinics and they were able to subsidize that. But as a clinic, they only receive a fee schedule, which is pennies compared to what you get for cost-based reimbursement. And so they basically had some great medical facilities over there, but because of reimbursement, they couldn't maintain the services that they provide. And that's why they started looking at cost-based reimbursement and the ways that they could increase their reimbursement and still deliver care. So I know they've gone through that. Bad debt and uncompensated care, we've touched on it, but it's growing, and I think it's going to continue to grow. We haven't expanded Medicaid in our state. We've lost a lot of jobs in our state with what's happened with coal. We had 450 people lose their jobs up in Campbell County alone during the legislative session. We've got higher deductibles and higher co-payments and out-of-pocket maximums that our payers are now paying those that have insurance, and it's harder and harder for them to pay that. So we've actually seen those numbers increase across the board throughout the state. I think the last figure that we came up with was $120 to $125 million of uncompensated care annually for our 27 hospitals. And that's their cost. That has nothing to do with their charges. That's the cost of delivering that care. And I would even venture to guess that that actual cost is higher than that, but that's what we're allowed to report. And I expect that to continue to climb. We talked about the pitfalls or the problems with governmental payers, the fact that they don't even cover the cost of delivering that care to those that receive it. And if those numbers continue to climb, I expect more hardship for our hospitals around the state. So I don't know if that helps or not. I don't know if you have questions for me, Chairman, or where you want me to go. I think we could start talking about my interpretation of the CARES funding and how that's supposed to be used. But
Mr. Boley, I really appreciate that overview because I think it's valuable for all of us. I know it's probably old news to our good Chairman of Labor and Health, but to all of us on corporations, it just helps us to be reminded of many of the things you and Franz have brought to the table. A couple of the bullet points that we have down for this afternoon are critical access hospital construction and small clinic construction. And that does play into what you alluded to as your next topic, Mr. Boley. And we would like you to touch on what your understanding is with respect to the CARES funding. Because I've been told a number of things. I've been told that we are allowed to utilize CARES funding for capital construction. I've been told that you can't, but I would appreciate anything that you can give us on those two fronts.
okay, thanks, Mr. Chairman. So I think the first thing, go ahead.
I'm sorry, Ms. Burley, but then we'll come to the opportunity for questions committee. So just wanted to allow you, Mr. Boley, to continue on through those points.
Okay, thank you, Mr. Chairman. So I think the first thing that I'd want to tell you up front here is, and a lot of you that know me know this, I'm probably the loudest and the strongest voice when it comes to advocating for our hospitals, and I'll fight tooth and nail to protect them. And so whatever happens in this discussion and whatever happens in the future, whether we get new hospitals or not, I'm not going to put myself between the hospitals and myself, because I'm going to have to advocate if they're built. I'm going to be there to help protect them and help them succeed as much as I can. And so I'm willing to provide as much information as I can, but I don't think I'm in a position to tell you I think this is a good project or a bad project, if that's okay, Mr. Chairman.
Okay, fair enough. Absolutely.
So when I look at the direction, and I've been studying this since the CARES funding rolled out, and I'm actually grateful for the special session, but I'm a little frustrated by the special session because of the $450 million or whatever that was allocated through that special session. We're still waiting on rules from the SLIB board on how we can access the $200 million that was put aside for capital purchases, capital construction, whatever it might be. But as I look at the direction, and I've talked with my peers in Washington, D.C., I've talked with our congressional delegates. My understanding is that CARES funding can be used for capital construction. And it can be used to help facilities either deal with existing pandemic or prepare us for a future pandemic. And I think the thing that we all need to realize right now is COVID's not over. As you look at states surrounding us, And I'll use Scottsbluff as a great example. Nebraska is seeing a huge spike right now as they have opened up their economy. Wyoming is bucking the trend, and it's amazing to me. And I hope we continue to do that. Arizona is absolutely going crazy right now. Some of their hospitals have reached capacity, and they're going to their surge plans down there. But COVID is not over, and it's a reality. And we're not going to be able to go back. We're not going to be able to close down the economy again like we did. And so our hospitals, our healthcare professionals, our long-term care facilities are going to be dealing with this for months to come, if not even into the next year. And so the CARES funding is there to help them if they need to build additional isolation rooms, if they need to create negative pressure rooms. I've got one facility that needs a new generator, and to me that meets the criteria because without that generator, they don't have redundant power, and if they have a patient on a ventilator, they don't have any power for that. So replacing a generator makes sense. Replacing air handling units makes sense. I think you could stretch it into the long-term care arena. And one of the things we found is that that this disease virus is deadly in long-term care facilities. And luckily, only 2 of our facilities have had positive cases. But of those, the one that had 11 cases, we've already lost 4 of those residents to death. And so when we have semi-private rooms, we're putting both of those residents at risk. So I think you could probably use CARES money to go from a semi-private room to a private room and do expansions on nursing homes. I think if there's equipment that needs to be purchased, ventilators or other equipment that could help us care for COVID patients or prepare us into the future, that's exactly what CARES funding was for. And I think that there is a whole list of these things out there that need to be done and could be done. The one thing I do know for sure is the money has to be expended by the end of the year. It can't be encumbered. It can't be guaranteed. My understanding is it has to be spent. And so I think that limits what we can get done in the next 6.5 months. And the longer we drag this out, the longer we wait to give direction, the harder it's going to be to utilize this money in existing facilities. I think there's some great opportunities and great benefits to this too, because as we start doing some of these projects around the state, we're going to put workers back to work. We're going to stimulate those economies, and we're going to bring revenue into the communities where those projects are going on. The money can also be used for testing. It can be used for supplies. And one of the things that I didn't touch on, but that you should know, is our stockpile for our state and our national stockpile were nowhere near what they needed to be for this pandemic. In the early days of the pandemic, we were scrambling, and we're still scrambling to get PPE equipment to nursing homes and hospitals across the state, as well as private businesses. And so one of the things that I would advocate heavily for as we look at the use of CARES funding is to make sure that we build our stockpile, our state stockpile, and allow hospitals to also create stockpiles so that we've got enough PPE to get us further through than we did last time. The state's done a fantastic job using what they had, and we've been fortunate, but we were definitely undersupplied when it came to being prepared for this pandemic. And then telemedicine is another area that CARES funding can be used in, whether it's infrastructure or whether it's buying equipment. But that's another area that is specifically designated in the CARES funding guidance from the Department of Treasury. So that's kind of where we're at.
So, Mr. Boley, thank you. A lot of really valuable information there. And, the thing that's in my mind, committee, is that we still haven't rolled out rules and regulations that have allowed our hospitals to benefit from any of that federal stimulus. And so with that as a backdrop, moving forward, whatever we do with CARES funding, I would suggest that we've got to figure out a way to expedite processes if we're going to get anything on the ground, because the way I have read that CARES Funding Act, I agree with you, Eric. I think it's got to be spent by December 30th or whatever. And boy, if you're talking about an addition to a hospital or even some component projects, it's pretty tough to get those drawn out and on the ground. But anyway, committee, any questions for Mr. Boley? Mr. Co-Chairman.
Thank you, Mr. Chairman. Mr. Boley, appreciate your testimony. When it comes to the possible use of CARES Act funding for the purpose of construction on clinics or replacement of aging infrastructure, my understanding was that would be targeted towards facilities that don't have the capability to handle these type of pandemics or handle these types of cases. Is that it, or can you talk a little bit about why, please?
So, Mr. Chairman, Mr. Co-Chairman, that's a great question. So, I think it could be used to update or to prepare a facility that's not prepared for that. Or my understanding or interpretation also is that it can be used to enhance what already exists. So a good example for you, I've talked with my hospital in Douglas. They have one ICU isolation room, and they would like to increase their capacity and have two ICU or isolation rooms with negative pressure. To me, that fits right in this, but they would have to do some modifications to their air handling unit and some internal HVAC work. I've got another facility that needs a new air handling unit and could tie it in to improving and increasing their capacity. I think that could be done. I'll use Crook County as a great example. They're the ones that really could use a new generator, so they have redundant power up there at Sundance, and I think that fits right into the criteria. I think you could do modifications or renovations to existing clinics too, and it is supposed to be for clinics. So one of the things that we've learned is you need to do social distancing and create barriers. So to create splash guards for the admission desks for the clinics, so that you're separated by plexiglass, so you can change the way that patients flow in and out of your facilities. That if you need to make modifications, that's all exactly what I believe the CARES funding is supposed to be used for. I'll also tell you to date, and I've got to actually, I'm just going to do this. Sage West, I know they're being targeted or they're being questioned, but Sage West has done such a phenomenal job. That is the hot spot of our state, and they have done such an incredible job over there. And the survival rate and those that have recovered in that community, it's unbelievable to me. But they're a for-profit chain, and so they're ineligible to receive FEMA funding to get PPE. And so all of their PPE has been done at their expense. Well, the CARES funding is supposed to cover that, and they should be able to use the CARES funding to pay for their PPE. To date, we still haven't been able to get any funding to even cover the PPE. And the hospitals and nursing homes around the state have spent 5 or 6 times sometimes for the cost of a mask or a gown, because that's the only way we can get it at their own expense. Yet we still haven't even reimbursed them for those expenses. And so that, again, I think that's another area that really needs to be focused on as we look at CARES funding and how it's supposed to be allocated.
Representative Duncan.
Thank you, Mr. Chairman. I have a question. So I spoke to my hospital CEO here, and they, of course, they are a Banner facility. They received the funds that the feds allocated directly to different facilities, separate from what the state allocated. Their problem is they still were waiting before we even went into session. They were still waiting for for rules and for how they could even properly use those funds. And to date, those rules are still a little bit fuzzy for them on what they can and cannot use. Luckily, Banner, I was told, they've had experience with Fed funds before, and that they were liquidity enough to where they set up a separate fund or a separate account. They took 400 million of those funds, or no, 400,000 of those funds, and set them aside, use those, but everything else that they received, they dumped into this separate account because they were too afraid to use those funds because of the strings that were attached to it. And so what can you say to that? Because a lot of our hospitals did receive funds, and they have funds to be able to do some of these projects, to do, take care of their payroll and to do things. So what is your status on all of that?
Mr. Chairman,
Go ahead, Mr. Foley.
Representative Duncan. First off, you have a great CEO there. He's fantastic. And you've identified a really difficult part of the whole CARES Act itself. Is just like the CARES funding that we're talking about, $1.25 billion the states received. I think there's been a tough go in trying to interpret what you can and can't do with those funds and what the liabilities are if you do it wrong. I'm intimately familiar with all the different money that's flowed into the state through the different tranches of CARES funding. And I agree with you. The guidance isn't very clear or direct in exactly how that money can be expended. When we take a look at what happened, $160 million of lost revenue across our 27 hospitals in the last 2.5 months. But the CARES funding is not supposed to be used to replace lost revenue. Yet we don't know exactly what it's supposed to be used for. I think what you identified is one of the big problems. Is there's some concern out there, and there are different ways that hospitals could go about getting different pools of money, and some of them had very clear strings attached to it. So you could go out and get accelerated payments, which basically means that you're taking advance payments from your Medicare clientele now. And you're getting 6 months worth of it now, and then you can spend it, but you have to turn around and repay it in the future. If you don't have any revenue, you're basically setting yourself up for disaster. And there was a 10.5% interest rate attached to those. So a lot of them applied for the money, and it's sitting in a bank account because they're afraid to use it. Some of the small hospitals, the Banner facilities, weren't eligible for it, but some of the other ones were able to get the PPP program because they had less than 500 employees. That's probably the easiest one for us to comply with. And then over the last 2.5 months, hospitals have received two or three different tranches of money. And a lot of times, and I'll give you a great example, our hospital association was able to write 2 different grants to bring in about $1.2 million that we distributed to all of our members. The last one was $950,000 that came in, and the money came before we even knew it was coming. And then we were told that there will be a letter coming sometime. This was 10 days ago. We still have the letter explaining why the money came, and they'll do a webinar with us eventually to tell us exactly what the accountability looks like. So we've distributed those funds out to our hospitals, and that's just a drop in the bucket compared to what they received through the rural tranche of money and also through some of the other tranches of money. And so we're trying to get guidance, and we're working with our national partners, but there is some huge concern. And in the meantime, those that are on the brink or on the cusp of trouble are having to spend the money and worrying about the repercussions, or else they're not spending it, and then they're having to furlough and cut patients. And we even heard examples of where the ER was being considered to be closed, and some of the other necessary services in those communities, which is just scary to me that you close down an emergency room during a pandemic.
So, Mr. Boley, I'm inclined to take a quick break for the committee here. I would ask you to stick around because we may have a couple more questions. One of the biggest questions, committee, that I want everyone to think about is it feels like we might be inclined to support something in this direction. Certainly, some of those renovations and component projects that Mr. Boley alluded to are intriguing to me. And by the way, Senator Nethercott has been doing some homework. It looks like SLIB has established those emergency rules. And do those construction projects then, would they route through the SLIB board? would we set up something else as a suggestion of how we would get that generator to Crook County, for example? So let's think about that. But in the meantime, I want to take a 5-minute break. We'll come back at 25 minutes after, and we'll pick this right back up. Okay? 5-minute break.
Thanks, Mr. Chairman.
Okay, committee, as some of our members make their way back, I do want to recognize that Representative Miller has been sitting in on our meeting this afternoon. We appreciate you being alongside Representative Miller, and we do have several who would like to provide public comment on this particular topic, committee members. And so we're going to get to them in just a moment. I want to give Mr. Boley an opportunity to kind of wrap up any thoughts he has. And if you can stick around, Mr. Boley, we would love to have you do that, because I'm sure there may be a question later on. But I think we have enough back that we can get started. So, Mr. Boley, how about some wrap-up thoughts for your topic discussion points?
Thank you, Mr. Chairman. I'll be brief. I know there's a lot still to go. I would just address that just today, the governor and the AG signed off on the SLIB board rules, so we hope to push those out. So that's good news. It hadn't happened until today. One of the last questions that you asked, and I think it's an important one, as we take a look at what we're going to do with the CARES funding, is how to get these plans approved as quickly as possible and put the resources to work. And that therein lies another problem with healthcare facilities. They have to be overseen by the state license and survey, which is a sub-department of the Department of Health. And because it's a healthcare facility, there are certain requirements that other construction projects don't require. So I've already talked with Director Ceballos and others within the department, telling them we need to come up with an expedited manner, and they think that they can keep up. Now, depending on the volume, we could run into some snags, and the longer, like I've said, the longer it takes for us to get approval, the longer it's going to take to try and get these things done. I will also tell you that I'm aware that one of the proposed new hospitals has already submitted architectural plans for consideration with the Department of Health. I think that just happened recently. But the construction of a whole new building it's a huge undertaking for the department to get those approvals in place. And there are a few shortcuts, and maybe one of the things we could consider, although CMS is kind of the 1,000-pound gorilla when it comes to healthcare construction, is if there was some way we could find waivers or things to expedite that work, we might be able to get a few more things done quickly. But even some of the simplest renovations that you would think should be a no-brainer, a lot of times they take several weeks to get approval. And so I would just caution the group that I absolutely think that's where some of this CARES funding needs to go. But we have challenges and we have hurdles in front of us to get an authorization and get those projects moving and off the ground.
Sure. How do we get them out there? Very good.
I don't have much more to add at this point, Mr. Chairman. I'll just kind of sit quietly and listen to the rest.
Well, I really appreciate it, Mr. Willie. As you know, I'm on the SBC, and I also serve on the School Facilities Committee and have for the past 10 years. And so that's what's in my mind this afternoon, is knowing that even on air handling equipment, or let alone the isolation room over at Douglas, just getting those projects on the ground is a very, very challenging thing in the time frame that we have. So anyway, good points made. And Mr. Boley, thank you for sticking around. Committee, we've had some patient folks in our meeting with us and in the waiting room for public comment. So I would like to get to that, and then we can come back at the end and have a conversation about where we think we might want to go. So let's start with Representative Miller. Good afternoon, Representative.
Hey, good afternoon, Mr. Chairman and committee. And I really didn't have anything prepared to comment. I was going to just listen in like I have during this session. And then we have Court McGuffey that was actually going to do a short 5-minute presentation on what we're up to in Riverton. And then whatever answers or questions you guys have. I was going to maybe talk at the end there, and I think Eli's wanting to comment also. So, Mr. Chairman, I'll just turn it back over to you, and if we could let Mr. McGuffey into the room, I think he'll be able to proceed.
Well, thank you, Representative. And before we do that, if Senator Bebout's in the waiting room, he gets the opportunity first because he has that SEN right in front of his name. Just like you had REP in front of yours, Representative Miller. I don't know if go ahead, Representative.
I appreciate that, Mr. Chairman. And Eli just tried to call me twice, so I don't know if he's having trouble getting in or what.
Well, he might be, and he might want to follow the herd anyway. So let's see if Mr. McGuffey is there, and we'll just move on down through. Jill, thank you. Mr. McGuffey, welcome this afternoon. If you want to unmute, the floor would be yours.
Awesome. Can everybody hear me okay?
We can. Thank you.
All right. Good afternoon, Chairman and members of the committee. I appreciate you giving me the opportunity to speak with you today. My name is Court McGuffey, and I am a fourth generation Wyomingite, and I live in Riverton. 2 years ago, I joined a grassroots effort to restore hospital services to Riverton and the surrounding small communities. In 2014, LifePoint, the company that owns the private for-profit Sage West hospitals in Fremont County, began to systematically consolidate the Riverton Hospital and move most services to Lander. While their website and leadership would lead you to believe that many of these services are still being offered, evidence on the ground indicates otherwise. Surgical services have all but ceased, and there hasn't been a baby born in Riverton since 2016. We have one of the best nursing programs in the state at Central Wyoming College, and now students must travel to complete their rotations because they can't get the necessary experience here. The Riverton Hospital used to employ over 25 doctors, and now they're under 10, with several of those being locums. The Riverton Hospital used to have 225 employees, and now they're under 40. I want to let all the members of the committee know how much we love those 40 employees, especially in light of the current pandemic we find ourselves in. These people are our family and our friends, and they've done a marvelous job with the limited resources they have at our hospital. Now, I don't want you to take my word for it. I've provided you a packet just to kind of show you and shed some light on what's happening here in Riverton. And I'd like to reference that now. I hope you guys have received it. On page 2, Franz Fuchs that spoke earlier today, we've been in contact a lot over the last couple of years, but he provided me with this data about life flights in Fremont County out of Sage West facilities to other facilities. Primarily Casper gets most of our life flights, but in 2014, when the consolidation began, we had 155 life flights out of the facilities here, Lander and Riverton. Last year, almost 1,000, a 600% increase. Here, a life flight card is almost as important as a driver's license. You know, I know some members of the committee have looked into this air ambulance issue. Franz worked on a report for Medicaid life flight data, and Fremont County has 12% of the Medicaid patients in the state, yet we account for 40% of the life flights in the state. So it's a tremendous burden to us and our family, patients that can't travel. These numbers speak for themselves. The next thing I'd like to bring up is page 3. It's a letter from Lisa Burton, the chairman of the Wyoming Surgeons Committee on Trauma, dated March 16th. And basically this letter says, and it was mostly Casper surgeons that are, because they see what's coming in via Life Flight. And they put this letter together, and basically it just says that stuff is coming in, broken arms, hernias, one even said an infected hangnail was stuff that they've seen. And unfortunately, like we've heard earlier in the meeting, a lot of this stuff is uncompensated care. So Casper and Wyoming Medical Center has been burdened with taking care of our folks that are on Medicaid. So the next item I'd like to talk about is a letter from Tom Forsland. He came and did a walkthrough of the hospital here, former director of the Wyoming Department of Health. And he basically concluded that our facility up here was operating nowhere near capacity after you read through that report. And then finally, I just wanted to let all committee members know, and you guys may have seen this before, the last, on page 8, there's a letter from the Casper, an article from the Casper Star Tribune about the costs here. And the Sage West hospitals here charge 800% over Medicare reimbursement rates. And I know being in Wyoming, like we've heard in the meeting earlier this afternoon, we don't have the volumes, so we've got to charge a little bit more, and I think we all understand that. But the rest of the state averages about 300% over Medicare reimbursements. We're at 800%, and so not only have our services decreased, but things have gotten very expensive. For these reasons, 2 years ago, we decided our only option was to build a new hospital. With $300,000 raised from community donations, a financial feasibility study was completed and confirmed what we had known for the last 60 years. Riverton can support a full service hospital. We have selected a hospital management company, and a contractor has completed preliminary architectural reviews and designs. Our hospital has a price tag of $35 million and will require $6 million of working capital to get started. Because of all the work we have put in over the last 2 years, we have been in touch with Laura Hudspeth at the Wyoming Department of Health, and our design plans can be finalized quickly and construction can begin immediately. Our project is shovel ready. As you all know, and we've spoke about earlier, Fremont County has been the hardest hit area of the state during this COVID-19 pandemic. I'm sorry to report we just had our ninth death yesterday. We plan to make our new facility the first pandemic-ready hospital in the state. We want it to serve as Western Wyoming's treatment hub for future pandemics. Through innovative design, our hospital will provide multiple beds and surgical suites with independent negative pressure ventilation systems to isolate sick patients and keep other patients and staff safe. Our contractor has informed us the cost of adding these types of ventilation systems is minimal, as long as they're planned from the beginning of construction. They also have informed us the cost of retrofitting hospitals of our size would cost millions of dollars to do. Our hospital will be telehealth focused to expand access, improve quality, and enhance safety during pandemic outbreaks. This new hospital will also dramatically improve health outcomes for tribal members. Cultural factors, as well as overcrowded living conditions, make tribal members more susceptible to pandemics. All of the 9 deaths in Fremont County have been Northern Arapaho tribal members. Both the tribes support our efforts, and in fact, the Eastern Shoshone tribe has offered to donate $1 million worth of land in the Shoshone Business Park just north of the Walmart here, the site where we plan to build this new hospital. The economic impact of a project like this can't be overstated. That's been mentioned before. It will create hundreds of jobs from construction to operation during a time when our state needs them the most. The last thing I'd like to say before I take any questions you might have is I really worry about the long-term viability of our Riverton community if we don't restore hospital services. I wonder what the people in Cody or Powell or Buffalo or Sheridan would say if somebody came in and said, you know, we're going to take away your hospital now, how that would affect those communities. I think it'd be devastating and to their economies as well. But that's exactly what is happening here. I was a dentist in my previous career in Colorado for 12 years. I just moved back to Riverton 2.5 years ago. And when I was here going to high school, we had a hospital. My family did. And we got care there. It was great. And now that is gone. I'm the CEO of 2 companies here in Riverton. I worry about being able to find young people like myself to come to Riverton and work here. And I worry about our retired folks who come to me and say, Court, I'm going to have to leave. There's no hospital here. And so that's why it's so important to get this done for our community. And that's why I've been a big proponent of it. The last thing I want to do is build something that isn't going to work. And we've put in a lot of time and effort. The former hospital CFO for the Riverton Hospital is on our group. We know what we're doing. We've elicited the help of experts around the country. We know that rural hospitals are a source of, they're struggling throughout the country, but we're happy to report that no rural hospital in the Rocky Mountain region has gone out of business in the last 10 years. We know it's a tough business, but we feel like it's worth going after, and it's too important to our community. With that, I appreciate the time you've given me today. I'd appreciate the support of the legislature as we move forward, and I'd be happy to take anyone's questions. Thank you, Chairman.
Okay, thank you, Mr. McGuffey. Question from Senator Scott.
Mr. Chairman, I've got some questions, and what I'm really concerned about is the potential viability of the hospital. My expectation is that you're going to be close to 50% Medicare in terms of the book of business, in terms of the actual work you do and the costs you incur. Are you expecting to be a critical access hospital, Mr. Chairman? Or is it expected to be a PPS hospital? And if it's PPS, do you expect what's going to be the reimbursement? It can't be a sole community provider status, can it? And I know there's difficulties in getting the critical access designation. You have to be under 25 beds. Are you going to be under or over that? And would being in the reservation help you with that? How does all that play out? Because I think that may be a key to whether the proposition is financially viable or not.
Mr. McGuffey?
Mr. Chairman, Senator Scott, thank you for that question. So we are unfortunately under the 35-mile designation that puts us in that critical access designation. There are some opportunities through the tribes that we're exploring, but we would set this up as a PPS hospital. Back before the LifePoint combined the hospitals under one license, in 2014, we were a PPS hospital. We've been that forever. We had profits of over $3 million in 2014. And and that was with being a PPS hospital. Senator Scott, I know you had mentioned before about the sole community provider status. It's not a 30% reduction in Medicare reimbursement. It's about a 6 to 7% reduction in outpatient services. And then you get a little bit of reduction per discharge, but it's not quite the 30% that you had mentioned earlier. But we have run all those numbers through our company, Stroudwater and Associates, that completed our feasibility study, and Eide Bailly, the premier healthcare accounting firm, is auditing our study right now to verify all the numbers. So we know the business is difficult, but we feel like our studies show that this can be very viable.
Thank you, Mr. McGuffey. Follow up, Senator Scott?
Yeah, Mr. Chairman, I really would urge a very careful look at that, because from what our experience was here in Casper when Wyoming Medical Center lost its sole community provider status, it's a much bigger hit than what you're talking about. I think it really is in the 30 to 40% range. And as I've seen some of the differences looking at Medicare reimbursements regionally, the sole community provider status currently is a big difference. And Mr. Chairman, I am frankly afraid that the upshot of all this will maybe that Fremont County won't have a financially viable hospital, because I think they'll affect what the status of lender is as well. So that's a point I think needs to be very carefully looked at. Medicare is so important to the success of these hospitals, and it's going to be low volume. You know, if Casper's having trouble and Cheyenne's having trouble getting enough volume to compete with the rest of the region, two hospitals in Fremont County are clearly going to have that trouble in spades. So Mr. Chairman, I'm expressing a deep concern and would like to hear more from Mr. McGuffey.
Mr. McGuffey, any further thoughts?
Yes, I appreciate Senator Scott's concern. Our hospital made $3 million when it was a PPS hospital in 2014 before they consolidated. We have looked into the reimbursement. I'd be happy to look into it again for Senator Scott and reach out to him and make sure we're all on the same page. But we've definitely, we still have 20,000 people on this side north of the Wind River, okay? And what we would like is 2 hospitals for 45,000 people in our county. Bighorn County has 6 hospitals for 50,000 people, or the Bighorn Basin. Okay, so there are plenty of patients here. You know, Sage West in 2018, they had an EBITDA of $14 million. Okay, and they are doing very well. I mean, part of that is because of what they charge, but you know, a magic wand didn't just go over Fremont County and all of a sudden we couldn't have a hospital anymore. I mean, it was a conscious business decision, and we feel the numbers support themselves to have a hospital. Thank you.
Thank you, Mr. McGuffey. A question from Senator Schuler.
Thank you, Mr. Chairman. I think you have a gallant effort. I think you hit the nail on the head in terms of what you need there. And I'm excited that you've made all the efforts you have to try to get this thing going. I guess my big thing is after, reading through the act, last week it just came out with the SLIB rules. And granted, the money is there to help improve healthcare delivery systems and infrastructure. And it does include, major renovation and capital construction. But I guess my biggest concern is that you're in the same category with the cities, towns, and counties who might also be vying for that money. And my understanding, unless someone can correct me, is this money is a first come first, whoever gets there first gets it, first come first serve. So I guess my big thing is, if you guys are as serious as you say you are up there, I would say that you better get cracking pretty darn soon. And someone let me know if I'm wrong on that. Thanks, Mr. Chairman.
Mr. McGuffey?
Senator Schuler, I appreciate those comments, and trust me, we've been cracking a lot lately. We're waiting for the application to come out. We heard it was going to come out this week. We've been in several meetings. We're waiting to see what the AG's opinion on how this money can be used. Of course, we're going to get our application in and have a seat at the table and make them tell us no, I guess, if it comes to that. But we're ready to go. We've been working on this for a long time, and we're just trying to find a way to get it done.
Senator Nethercott.
Thank you, Mr. Chairman. Thank you, Dr. McGuffey. It's good to see a fellow Wolverine up here on the screen. I appreciate you moving back home and all of the incredible work that you're doing there. I can tell this committee and the legislature and all the people watching that the town of Riverton desperately needs a hospital. I grew up there with one. It was vitally important to my family who experienced all those major life events there in their community hospital. And so it's very important to see the success of this for our Wyoming community that's in the heart of our state. So unlike all of these other hospitals that we're trying to support, like here in Cheyenne, where the biggest challenge is leak to our outer borders, there is nowhere for the folks of Fremont County to go. They really need that localized hospital. One thought I want to ask you about, because I've heard Senator Scott's concerns about the road to hell can be paved with good intentions with having 2 hospitals within that 35-mile radius. Have you consulted with any attorneys, or have you found any precedent to establish an MOU between what would be the Riverton Medical District and the Sage West and Lander to essentially have some type of legal document to indicate that you have one purpose or mission to maybe obviate or work around that 35-mile connection, so we don't have to talk about that anymore, and hopefully just move it through as a possible idea?
I'm looking at the bottom of my screen, and it has 4 different folks from Fremont County, all of whom I'm anxious to get to. Representative Miller, I saw your hand up, but I'm going to come to you, Mr. McGuffey. I think you can start with the answer to that question from Senator Nethercott.
Thank you, Chairman. Good to see you as well, Senator Nethercott, again. We have our feasibility study is based on our primary service area. So that is the over 20,000 people north of the Wind River. So we don't plan to take any patients away from Sage West Lander whatsoever. We want Lander to have the best hospital that they can have. And we don't need patients from over there to be successful. I have had several meetings through the 2 years that I've been back here with some Sage West leadership, and they just haven't amounted to much. And so that's all I can say about it is our numbers are based on the 20,000 people on this side of the county. And we want Lander to have the best health care they can have.
Follow up, Senator? Okay. Representative Miller, you had your hand up, and thank you for your patience.
Well, thank you, Mr. Chairman. And again, we've covered a lot of ground here, but I had my hand up to help with Senator Scott's question, because he's been around a long time. He knows these issues, and I note his concerns. We all have those same concerns everywhere we're working in Wyoming to make sure we have viable communities. But I just wanted to add a couple of points that I haven't heard yet. Number one, this will be City of Riverton owned hospital. Number two is everything was fine prior to 2013 when the two hospitals in Fremont County were separately owned. Frankly, we had a lot more doctors in both communities, and everyone and the two hospitals competed with each other. Competition is a good thing. And we actually think this hospital will improve the Lander Hospital too, because there's not just one guy now that you can go to. And the final thing is, and this is especially for the Casper folks, is the life flights since the merger have progressively gone up to where there's 600, it's a 600% increase, nearly an average of 3 life flights a day for things from hangnails to a minor fracture in a bone are being life flighted out of our community. And you know where they go? They go to Casper. So I think this actually impacts the Casper community also. So Court may want to expand on some of that stuff, but just wanted to get that in briefly.
Mr. McGuffey, I'm going to let you pause for the cause for a little bit here. And I want to get to Senator Bebout. And I see Representative Salazar has joined us. It's good to have both of you here. But Senator Bebout, if you'd like to unmute and share some thoughts, we'd appreciate that.
Yeah, thank you, Mr. Chairman and members of the Corporations Committee and the Mr. Vice Chairman. It's good to see all of you this afternoon. You know, being an engineer, I thought I was able to understand IT, and I've been listening all afternoon, but couldn't get my face up there. But thanks to LSO, they bailed me out. And so I do have a couple of thoughts, Mr. Chairman and members of the committee. And actually, I would like to wear 2 hats. The first hat is just as a citizen of Riverton, and like Senator Nethercott and Court McGuffey and others, I've lived my whole life in Fremont County, and my brother and sister they gave birth. My mother gave birth to them in Riverton, so we've had a real close relationship with the Riverton Hospital. So that's the first thing, Mr. Chairman, briefly. Then the second thing I want to speak to you as a member of the legislature a little bit about COVID funding. As far as a citizen, Mr. Chairman, everything that's been said by Court and Dave and possibly Tim will chime in about the need and the demand for a hospital north of the Big Wind is accurate. I'm not going to add to that. I appreciate Senator Scott's concerns. The one thing that I've always been very careful about is when you build things, you have to look past the building of them and be sure that the cash flow and the proper planning and business model works, so that you don't build something and then have a situation like we have in our state and other areas where it's easy to get them built, you find the money, but then you can't sustain them. And I've analyzed and looked at these financials and those documents, and I really believe that we can make this thing work. And it was well said by Court that we're not in here to compete or put Lander out of business. They have their situation, they have their people and their patients. We want ours back, and we can do that. And will it be difficult? Absolutely. And we're moving ahead, and we're trying to get the financing in place, and that's a decision that we'll have to do locally and how we raise the funds and what we do. And there's a lot of different avenues we can pursue. That's something we will do locally at this particular time. And so I think all of that's viable. There might be some ways working with the tribes, and because of the situation that exists on the reservation. I know there's a demand out there, and it's been said many times that good, bad, or indifferent, we are the epicenter of the COVID in our state. And so one of the things that I want to talk about, Mr. Chairman, I'll be a senator for a little bit, is the use of the COVID funds. And as I looked at the guidelines, and by the way, Mr. Chairman, I've been speaking to both Senator Barrasso and Senator Enzi. I asked a question, well, where are your rules? Why are you using guidelines? We always use rules in the legislature. Their response was, it takes too long to do rules. We came up with guidelines so we could get the money out the door. So those guidelines, as broad as they are, is my understanding is they will be what we use. When I read those guidelines and look at the interpretation of them, there's several things that come to mind. And one of them is, I think, with the language in there under temporary, and then you see the word and, or you see the word or, you've all read those. And, you know, that might be something that we might be able to tweak, don't know. But the other side of it is anything we can show that's really COVID related, I think is without a doubt something we could utilize those COVID funds for. And as I look at not only the hospital in Riverton that we're planning on building, but other places in the state, I think when you look at the negative pressure rooms, the isolation, and when you look at a hospital, it's got a price tag of 35 million, I think, and we're trying to come up with these numbers, Mr. Chairman, but I think for COVID related funds, be able to provide a center for the western part of our state with reservation, on reservation land, working with the, IHS and some of those things, we can come up with a substantial amount of money that would go to building the hospital, but would be utilized because of COVID funds for this dreaded pandemic we find ourselves in. So I think in that sense, it's a win-win situation for the state, for the use of those funds, for the tribes, and for all of those issues. So I think those funds are available, very available, and could be utilized. As to whether we go with Riverton without those funds or not, we're going to try to move ahead, Mr. Chairman. There's a lot of bumps and bruises along the way. Critical access on the tribes might be something to consider. The one thing that I would point out as a citizen looking at this, and before when we had two hospitals, there was profitable on both places. Riverton was the most profitable. And I understand corporations and I understand profit business. I'm a businessman. And when they combined into one single operating unit here, they were able to, in fact, have about a $4 or $5 million benefit rather than having two separate units. So obviously that would drive that decision to bring the two together under one umbrella, and you would have the extra money that came in. I get that. But when they did that, what they decided to do, and I'm not sure why, Mr. Chairman, but they really let Riverton go as a full-fledged hospital. And that's the big gripe I've had all along with this is we don't have a hospital. We've got just a high-level Instacare up here, and that's just not right. And one thing I will say about in defense of Sage West is they have done a good job on COVID. I won't argue that point, but I'll be glad to answer any questions, Mr. Chairman. That's a quick synopsis of my position as both a citizen of Fremont County, Wyoming, most of my life, and as a sitting senator. Thank you.
Thank you, Senator. Appreciate you being here this afternoon. Committee, any questions for the senator? Okay, I want to get to Representative Salazar. Welcome this afternoon, Representative. You have the floor.
Thank you, Mr. Chairman, and thanks to your committee. I see a lot of friends here. I'm going to just make my comments very brief. As someone said earlier today, COVID's going to be here for a while. This is phase one, and I'm afraid that we may be facing COVID again in the fall or winter. So this is going to be an ongoing issue. The second thing is, Fremont County, as all of you know, is ground zero for this. Take a look at the numbers. We have a disproportionate number of those who have tested positive over any other county. We are in need. Fremont County is in need of true health care. And this is so important to our folks in Fremont County. Thirdly, Fremont County has a very, very large population of seniors. As you all know, they're incredibly susceptible to COVID-19. If you take a look at the small town of DuBois, we have a large population of seniors, and yet to get health care, they're going to have to go 80, 90, 100 miles before they can even get healthcare services anywhere. And that's assuming that we have something in Riverton. We need a new hospital in Riverton. And I honor our healthcare workers in Riverton. They are doing an incredible job with what they have, but we need something full service. We need a real hospital in Riverton. And when I talk to people in my geographically large district, over and over again, I hear from folks saying, we need something in Riverton that will give us true health care. And that's why you look on the screen and you've got a vast majority of the Fremont delegation here. We've got boots on the ground in this area. We know what's working and not working. And in my opinion, we do not have a full service hospital in Riverton, and our folks and our community know that. And we're coming to you to let you know that we as a community need this. We need this full service new hospital in Riverton, particularly because of what COVID has done to Fremont County. And so when you hear us talk, all of us talk with passion, because there are literally thousands and thousands of people behind us who believe the same thing that we're telling you today. And we ask for your help. We ask for your support. And with that, Mr. Chairman, I thank you for giving me a moment to express my concerns as well. Thank you.
Representative, thank you. Committee, any questions for Representative Salazar? Okay, back to Senator Bebout.
Yeah, thank you, Mr. Chairman. One thing that I wanted to mention too is again wearing my Senate hat, and you know this thing about COVID funds is more than just Riverton and Fremont County. It's Pinedale, it's Saratoga, it's northeastern part of our state, it's something in Thermopolis, different areas. And the Senate Appropriations Committee, we were looking at the CapCon bill not yesterday, but day before yesterday. And one of the things that was discussed during that meeting is to be able to go in and if we do have a CapCon bill, if we do have a special session, not if, but when, that we would put under federal funds COVID money and set aside X amount of money to be utilized for these rural hospitals around the state. And it would all be contingent on, of course, the funding be available. And I really think there's an opportunity to do that. And so that's a thought out there, Mr. Chairman, for your committee, is that the Joint Appropriations Committee will be looking at trying to do that. I think that would be provide maybe a little bit more direction if the legislature saw fit to do it on how we could spend some COVID funds for our rural hospitals.
Thank you, Senator. Mr. Co-Chairman.
Thank you, Mr. Chairman. My question for Senator Bebout and the rest, and anybody else, do you think that's necessary to include that in any kind of CapCon legislation? Just based on what we did during the special session, I feel that we've already set aside funds. We've already made that readily available for rural hospitals to be able to utilize. Do you feel that something else needs to be adopted? Is there action that's needed by this committee?
Senator Bebout or Mr. McGuffey or anyone like to take a stab at that? Mr. Appropriations Chairman.
Well, thank you, Mr. Chairman. Good question, Tyler. I appreciate that. And the way I looked at it is clearly in the legislation we passed, it would be in Senate file or House Bill 1001 with the first 485. That's out there and it'd be available to do it. And I think Senator Boner and I might have been you that helped put that language into that bill. So yes, I think that's accurate. The thing I would add to that is that it's just another way that shows of the legislature's intent specifically that these COVID funds would be used in that manner. Could you do it with strictly the way we're set up now? Sure. Would this help to get it done? Possibly. And that's why we looked at it, just to once again let people know that if the legislature was so inclined to do that and try to appropriate or dedicate those funds in that manner, that we would do that. And the one thing I get around to, Mr. Chairman, is we got $1.25 billion available in COVID funds, and I worry about how much we're going to get out the door in this short time frame. And it looks like, I don't know what the latest count is, maybe 25 or 30 million, but I do know that we had some good results the other day with the Business Council on our small businesses. So I hope that answered the Mr. Co-Chair's question.
No, I think follow up, Mr. Co-Chairman.
Yeah, thank you, Mr. Chairman. And yeah, I think that's to the Chairman of Appropriation. I think you're right. I mean, ultimately, at the end of the day, I think when it comes down to this 1.25 billion, and we're looking at we're starting to get to the end of summer, and we don't have a plan as far as getting these funds out. I don't know of anybody in the state of Wyoming that's going to get their feelings hurt by the state of Wyoming looking towards sending more money to our hospitals. I think everybody's pretty well on board with that, whether it's just renovating or building new capital construction or buying PPE. I think that's right, and I'd be supportive of those efforts. So thank you, Senator.
Appreciate it, Mr. Co-Chairman. We have the mayor of Riverton standing by, and I do want to get to him, and I would invite our legislators to please stay with us if you'd like. You don't have to exit the premises, but I do want to bring Mr. Richard Gard in so that he can provide us with some testimony. Mr. Mayor? I think hopefully Jill will have him on board in just a moment.
Chairman. Chairman, thank you for the time. I appreciate.
Mr. Mayor?
Can you hear me?
I can, and you might want to turn down your YouTube.
Yeah, I just did. I muted off. I'm sorry.
I think we're all set then. Thanks.
Thank you very much. I do appreciate the time, Mr. Chairman and committee members, for the opportunity and the opportunity to explain a few things. I don't want to take much of your time. Being the mayor of Riverton, you could probably suppose the fact that I am very much in favor. With that, I would like you to know that the community of Riverton is very much in favor of this enterprise. And they have put a considerable sum of money up to make sure the feasibility studies and those things are been done, and that we can make a successful hospital. We don't want to build something that doesn't work. We have lost services over the last 5 years, maybe even longer than that. I'm a father of 6, my wife and I. 5 of those children were born all 6 were born in Fremont County, 5 in the Riverton Hospital. And so we think that OB may not be a profitable health center, but it sure is if I'm the mayor trying to recruit people to Riverton, Wyoming for businesses and other usages. I desperately need a full functioning hospital to do my work. As you guys know, Riverton is in the top 10 in population in the state of Wyoming. And with that said, it's vital that we have a hospital that allows us to continue to grow and be a economic center for the state of Wyoming. We truly have, and I think Court pointed that out well, we truly have turned into a helicopter pad and an emergency aid provider. And that has put a burden on the others throughout the state and other areas that receive our patients. And we would like to get back to the fact that we're taking care of our own. The new hospital, I think, is something that the community will back. I think we have cooperation with the tribes on what we're talking and what we put forward. And I think that will make a big benefit to what we're doing. And as the mayor of Riverton, I would pledge to work as hard as I can to help this come and be a successful operation for the city of Riverton. I do appreciate your time. I appreciate the efforts that you guys are doing for us. And we look forward to anything that we can do to further this project. Thank you, Mr. Chairman.
Yeah, really appreciate you being here this afternoon. Thanks for your patience. Thanks for hanging in there. Committee, any questions of the mayor this afternoon? Thank you, Mr. Mayor. And I believe I don't show anybody left in the waiting room for public comment on this issue. But Jill, maybe you could correct me in a moment if I'm mistaken. But let's go to Senator Bebout.
Yeah, thank you, Mr. Chairman, members of the committee, and Mr. Co-Chair. Very briefly, I want to thank you for taking the time to listen to us about this important issue to not only Fremont County for our hospital, but for the rest of the state and rural hospitals in general. Thanks for doing that. And Bill, as we move forward on this, and what I was wondering of you and the co-chair, how you may want to interface with the JAC. I don't know if this is more of a listening session from your perspective for corporations, if you're going to do anything, or if you want us to try to do something or move forward. But I look forward to working with you, Mr. Chairman, and you, Mr. Co-Chairman. If there's something you want to do or how you want to do that, just let me know. Thank you.
Senator, thank you. And just a couple of quick comments in that regard. I think we're going to certainly take that up right now, and we're going to get a flavor for where the Corporations Committee would like to go. But it was in the back of my mind, Mr. Co-Chairman, that it could be that we could simply send communication of support and recommendations that way through our appropriations committee, because you and others have already set up a framework there. But I just throw that out. We can think about that, and we'll take up that conversation here in just a minute. Mr. McGuffey, excuse me, I'm sorry, Representative Clem, you've got something for us.
Yeah, thank you, Mr. Chairman, and forgive me if somebody answered this previously, but in listening, I didn't hear it come up. I'm curious as far as what is the history, if any, in particular in Riverton, of that community ever forming a hospital district? Is there any interest in doing so? I understand with a for-profit hospital, I think that would be complicated. But I don't know of the history of using existing mechanisms as far as a hospital district or a rural healthcare district in that area. And if you could help me, I appreciate the conversation and understand the predicament, particularly that Riverton is in. I know we have existing measures that can be utilized. I'm just wondering if they have been utilized or if they ever were in the past. Thank you, Mr. Chairman.
Mr. McGuffey, would you like to handle that one?
Sure, Chairman. Representative Clem, thank you for the question. A brief history here. Back in the early 80s, both Riverton and Lander hospitals were county owned, and through our commissioners became unhappy with the management companies back then for whatever reason. I was 3 years old at the time, so I don't know what went behind that decision. But at that time, the commissioners decided to sell both the facilities. They sold both hospitals to different for-profit companies. And so that's why things worked in Fremont County for so long, is because two different for-profit private companies own the hospital, and they worked together, they competed against each other. And care in both towns was very good. When Senator Nethercott and I were here in high school, our families received great care and it worked good. But when things changed is when one for-profit took over both. And it became more about how do we increase profits than improve the care for the citizens. So that's how we stand currently.
Thank you, Mr. McGuffey. Representative Miller.
Thank you, Mr. Chairman and committee. And again, to Representative Clem's question, the plan is for the current hospital plans to be owned. The hospital itself will be owned by the city of Riverton. And there'll be a board of directors that are all Riverton or Riverton associated running that hospital. And there will be a hospital company that comes in to manage it. But it'll be a Riverton City municipality owned hospital. Thank you.
Okay. Once again, representatives, Senator, thank you for your time this afternoon. Feel free to stick around. Mr. Boley, I appreciate you as well. I don't know if you have any final comments before we take this up committee, but I thank you for everything today, Mr. Boley.
Welcome, Mr. Chairman. Appreciate the conversation. And I know we presented a lot of information about healthcare. I think it's important that you have that for background. The only thing that I might add, with the amount of money that was allocated that the SLIP board now has, if hospital construction is allowed to come out of that, I think, I'm not sure 200 million is going to be enough with some of the other renovation projects that need to take place across the state if we factor in long-term care facilities and other hospitals. One thing I might also add, and I know that the Labor, Health, and Social Services was looking at it, but you've got other facilities that are not as far down the line, but have faced some tremendous challenges. Rollins Hospital is a great example. 2 years ago, their hospital was hit by lightning, It fried all the electrical, including their elevators, their phone lines, everything. They had to redo that. And then during our session, I think it was, or just before, their old pipes burst. They had to go on diversion, flooded their MRI machine, their CT machine. And you know how important that facility is. We had that 100 car pileup during the session where they had folks in their cafeteria. We got other facilities that have gone out and got USDA grants. Hot Springs is a great example of that. Thermopolis, where they're repaying loans. And so I know Labor, Health, and Social Services is also looking at opportunities to maybe help forgive those loans. But we're going to need some of that additional CARES funding if we, depending on the scope and breadth of what we allow or what we consider with the CARES funding. That'd be my last comments.
Thank you, Mr. Boley. Committee, that kind of wraps up our discussion this afternoon on hospital facilities and maybe some of the potential items that we may want to consider. Mr. Co-Chairman, I'm going to start with you to maybe see what your thoughts are as to what we might want to consider and where we might want to go with this.
Thanks, Mr. Chairman. I think this should be one of those topics that we leave on our schedule to keep talking about as this transpires and moves along through the process and as hospitals are applying. I will state that I am disappointed in the Department of Health for not considering putting Sundance on that list of their hospitals they were looking at, but oh well. Nobody likes Northeast Wyoming, I guess. No, but in all seriousness, it is a ton of information. I've had more than one of our committee members message me that please never send me to the committee, to the health committee, because these are a bunch of corporate law wonks, so kind of outside of their wheelhouse, and mine too. And so I think really the only thing we can do is keep it on our agenda for the next go around, monitor its status, and then send a letter to the to SLIB in regards to our support for these types of projects.
You know, I appreciate that, Mr. Co-Chairman. And before I go to the committee, I've had in the back of my mind, you know, the need for communication. I really believe that we need to consider sending at least a message if it is the will of the committee that we support doing some additional things for our hospital network out there, then I think we should state that. And I think it would be helpful. I've seen the good chairman of appropriations shaking his head, but I think it would be helpful for them to receive that on appropriations. All that does is just broaden the base of support and give the message, as the co-chairman said, to SLIB and others, that I have been convinced this afternoon that we may have to put some additional dollars on top of that 200 million if we're going to specifically try to help Fremont County, specifically try to help Crook or the Saratoga Hospital, Sublette County. We're talking about bigger things. And my concern, committee, on top of all of that said, I think we do that anyway, but then the concern becomes what we face on school facilities or the SBC. How in the world can we roll these things out quickly enough to adhere to the tenets of the CARE Act funds? So, Representative Duncan, I think you had your hand up, or maybe not. Any other comments, committee? Senator Nethercott.
Thank you, Mr. Chairman. I don't know if you're ready to take action and make a motion here, but I think the time is now. I would move the committee to have LSO draft a letter on behalf of the committee, both to the SLIB board and to JAC, acknowledging our support of approval of CARES Act funding for the Riverton Hospital District.
Okay, I have a motion on the floor and a second by Senator Schuler. Discussion on the motion. Mr. Co-Chairman.
Thank you, Mr. Chairman. And I appreciate how much of Riverton showed up to testify about this. And I agree with Senator Nethercott, and I'll be supportive of it. I do think that there is a lot of merit, though, in including any of these projects that we've heard about.
Are you suggesting that you wanted to visit with the senator about an amendment to the motion?
Yeah, Mr. Chairman, the ideology would be to support any and all projects to that better improve our hospitals throughout the state of Wyoming.
Mr. Co-Chairman, I would not consider that friendly. That said, obviously we all support all of our hospitals throughout Wyoming, and the Senate File 1 that was passed in this last special session indicates the support of those capital construction projects and all hospitals throughout the state. That the funding is to go to that. But I think we heard a very specific need from a very specific population in our state that is specifically impacted by COVID, right? Which is Fremont County. So this money, I think, is even more uniquely situated to be appropriate for those COVID related expenses for this particular hospital that needs to provide the service in this very critical time, right? Both to the tribes who support this project, that support this service, and that are heavily impacted by COVID, which is what this money is specifically for. So I think that there's a distinction here and a priority to be given to this particular hospital and this project, and certainly not to the exclusion of any other project, but a priority perhaps for this one in light of those unique distinguishing factors.
Senator, thank you. I want to go to Senator Case first, and Representative Clem, I'll come to you after the good senator. Senator Case.
Thank you so much, Mr. Chairman. You know, it's a dicey issue over here in Fremont County. I want both communities to have healthcare facilities, but it's become such an us and them, and I think we're kind of not recognizing that there is facilities in Riverton now that belong to this company, and I actually think there's another solution in the works or possible besides building and standing up a new hospital in Riverton. So I'm not as enthusiastic about the motion, only because it seems very wasteful to me. There actually is a hospital building in Riverton now. There is I know folks are unhappy with the current provider, and quite angrily so, and would like to build an entirely new one, but that strands a lot of investment. It perhaps is not reflective of the efficiencies all across the county. So, Mr. Chairman, I'm hesitant for this committee to weigh in at this time. I want a solution that makes everybody happy. I truly do, but it may not happen here. But I think there's a lot that folks can do to come together, and they're so polarized. I'm disappointed in both parties, actually, and I hope for something better. And it's a very local fight, everybody, and you're going to jump in on it with both feet. And I'm not sure that's appropriate.
Thank you, Senator. That comment you made about how polarized it is, I make that comment every morning over my morning coffee, society in general. But anyway, Mr. Co-Chairman, you had a thought, but I do want to come to Representative Clem.
Yeah, no, Mr. Chairman, I think it's a really good point by the Chairman of Revenue in regards to jumping in on this single issue subject. I'm in favor of sending a letter. I'm in favor of Riverton getting their hospital back, but I'm not in favor of a letter specifically only on one project. I think that's like the good Chairman of Revenue said, jumping in the middle of a kind of a hornet's nest and an individual fight. So against the motion as it stands.
Okay, thank you. Representative Clem, sorry about that.
No problem. Thank you, Mr. Chairman. Senator Case shared many of my same sentiments. I struggle with this for a variety of reasons. One is we're just getting introduced to the topic, and much like yesterday when we were even discussing the state health officer and those powers, we didn't have everybody at the table. So likewise, there's many needs throughout the state of Wyoming, and we've heard about this one. And while I am sympathetic, I'm hesitant to go ahead and throw the whole entire weight of the corporations committee, the weight of that into a letter in support of one particular hospital for these COVID-19 funds. I think that the legislature spoke loud and clear when we did put that in the bill for the SLID board, giving our authority and our direction to use these COVID-19 funds as the SLID board saw fit. And so I think the direction clearly is there. I certainly would not begrudge and would encourage those that were here advocating on behalf of Riverton to do that in front of the SLID board. But at this time, I think it's a little, our vision is a little myopic. I think if we were going to do something like this in which we were going to prioritize the spending of these funds, then we should have had everybody at the table. We should have looked at Crook County. We should have looked at Weston. We should have looked at the whole gamut if we were going to prioritize something. So I'm not in favor of this motion, but certainly, you know, we went ahead and we passed some bills saying that these COVID-19 funds were appropriate for these hospitals. I still stand by that, and I believe SLID knows that as well. Thank you, Mr. Chairman.
Representative Clausen.
Thank you, Mr. Chairman. And this may be a question for Senator Case or someone that knows the specifics of this issue, I guess you'd say. But looking at our time frame for new construction, has there ever been a conversation of the city of Riverton purchasing that hospital that's already there? And I don't know the condition of the property or anything like that, but could these funds be used to purchase the property that's already there, and is it sufficient? I guess those are some of the questions I have before I jump into support of a totally new facility. And if these things have been worked out, because once again, it's if this facility is up to par and it's simply a management or the services that it provides that the city is short, that maybe there's another solution that we can use CARES Act funds in a timely manner that doesn't require construction. Just a question for those involved.
Representative, for what it's worth, that's a great question. So Senator Nethercott, go ahead.
Thank you, Mr. Chairman. And just to allow, I think Dr. McGuffey might be a good person to rely on if the chairman will allow it to answer this question potentially. Just to provide some clarification to my motion, this is just a letter of support for the Riverton Hospital. We're not asking SLIB to prioritize it to the exclusion of any other. We are not asking them to appropriate a specific amount of funds. It's simply just a letter of support from this evidently very powerful committee to the SLIB board in acknowledgement of the Riverton Hospital District. That's it, right? And so I think stating a letter that says we support all rural hospitals in Wyoming probably is meaningless and somewhat moot and ineffective. So if we're gonna write a letter in acknowledgement of a special need, that special need is in Fremont County that we all are acutely aware of as a result of the deaths that continue to occur there. So that's why it's not a specific appropriation. It's not to exclude anyone else. It's just to acknowledge that this unique opportunity that presents itself in a very unique community that has this very specific need. So I don't want to get ahead of ourselves into the significance or I think specificity that this letter of support may indicate or what my motion actually intends.
Thank you for that clarification, Senator. And Senator Case, maybe as an answer to the good representative from Glen Rock or other issues.
Mr. Chairman, I'm going to try to answer the representative from Glen Rock. Mr. Chairman, I think a different organization buying or it probably wouldn't even have to buy it. I mean, the Riverton Hospital could serve Riverton under new management and ownership. I'm convinced of that. I think the parties involved, at least on the Sage West side, would be willing to go to arbitration. And I think there's a lot of potential. That hospital facility, it physically exists, and we have to account for it. If a new hospital comes up in Riverton, then that one is a stranded investment, and that's a consequence of our actions that kind of sullies the landscape of healthcare in Wyoming. On the other hand, I think the facility might be available for new management. I'm not trying to necessarily encourage that, but I would like to really think the parties ought to get together and move towards a new level of thinking about this with a lot of things under the bridge. I don't support the motion. I don't think it's constructive to that. And it kind of puts a thumb on a scale. So I'm torn by everybody that's talked today, and I understand that Riverton really wants some more independence and direction and a healthcare facility they can call their own. I think we'd probably get that within the framework of the hospital that exists there now, but under new ownership and management.
I'm going to break with protocol a little bit here and jump outside the committee and allow Mr. McGuffey to answer that question. So, Mr. McGuffey, go ahead.
Thank you, Mr. Chairman. I didn't know if I was allowed to raise my hand or not, but I know the answer to Representative Clausen's question. We have met with, Sage West has had 5 CEOs over the last 6 years. So leadership has changed a lot. We've met, since I've been back, I've met with the current CEO several times, along with Senator Bebout and our other leadership in Fremont County. We've asked on 3 separate occasions to buy our hospital back. We want to buy it. The facility is not, it's actually better, a little bit newer than the Lander facility. And it still works. And we've tried that route, but that would affect the monopoly they have here in Fremont County. So we've gone that route and haven't had success.
Okay, thank you for that, Mr. McGuffey.
One more thing, sorry if I may. This past November, and I forgot, LifePoint sold the physical structures in a REIT to Medical Properties Trust. Okay, our hospitals were part of a 10 hospital package throughout the country, and they sold for $700 million the physical structure. So LifePoint at Sage West, they don't own our structures anymore. So it's kind of out the window now. If we can buy our building back, we'd have to approach a different company now. But I mean, this is what we're dealing with, corporate America here. And here we want to take charge of our local healthcare. So the opportunity to buy it back has changed.
Mr. McGuffey, we both know a good attorney, and she's right here on the screen. So committee.
She's a Wolverine, not a tiger, but we're all mammals, so it's fine.
Yeah, there you go. So
Senator
Scott.
Mr. Chairman, I got 2 points to make regarding the motion. One, it's not clear to me whether it is support for capital construction for the Riverton project or not. The point I would make generally is with the COVID deadlines, I think any capital construction projects at this time, this is different from it was time of special session. If we had a special session tomorrow and endorsed capital projects beyond the kind of remodel that Mr. Boley was talking about, frankly, I don't think we can get them done within the time frame of the CARES Act. I think we're kidding ourselves. We think we're going to do much more beyond a few remodel type of projects. You just can't get the approvals out of the bureaucracy fast enough, and then you can't get the physical work done fast enough to meet the COVID deadlines, or the CARES Act deadlines. So I think that's one thing we need to consider. Second, on endorsement of the Riverton Hospital, I think we need to be pretty cautious about that. You have to look at the economic viability of this thing long term. And doing that, you have to recognize that this isn't a pure private sector proposition in terms of your market. It's a government dominated one. And it's specifically a Medicare dominated one. They're probably half your patients, close to it, maybe more, maybe less. And that percentage has been gradually going up, and it is gradually making some of the past history irrelevant, because Medicare is continually being a larger share of the business of hospitals. Frankly, I don't fully understand the Medicare formula. I know enough about it to be good and dangerous. I am deeply concerned that the way the Medicare formula works, that having a second hospital in Riverton, given how close Riverton and Lander are, has the risk of adversely affecting the Medicare reimbursement for both hospitals and removing a good part of the financial viability for both Fremont County hospitals, which would be a major problem for us. I'm not sure it will do that. I wish I understood exactly how Medicare works that formula. It's more than a little obscure, but I have seen what's happened elsewhere when you lose the sole community provider status and some other factors in that reimbursement formula. I just don't understand. And I'd be concerned, Mr. Chairman, as a committee weighing in on this at this point without understanding that. Frankly, I think it'd be much better if Fremont County could somehow work out a compromise. Clearly, the current situation is too destructive of the Riverton community in terms of what it's not having a real hospital there, what that does to your economic development prospects, what that does to your viability of your community long term. I can sure see where they're coming from, but I'm not sure that the solution of them building a new hospital is one we can live with either, Mr. Chairman. So for those reasons, I think I would oppose the motion that's on the floor, Mr. Chairman.
Anybody else? Back to Senator Nethercott.
Thank you, Mr. Chairman. Kind of back to some clarification on the motion. So I believe Senator Scott expressed his first primary concern was capital construction and the time now that is upon us, because the expenditure of those funds has to be by the end of this year, of course. And so doing any kind of construction looks very grim. However, I believe that the wisdom of the SLIB board in granting those funds can ask those questions and make those determinations for how that gets allocated to ensure that it is compliant with the U.S. Treasury guidance. My motion did not limit how those CARES Act funds should be utilized, any kind of limitation to capital construction or not. I believe we leave that at the discretion of the applicant of the funds, which still has to take place. So the Riverton Medical District would still have to apply for the funds and identify those needs and how those funds would be utilized, again, consistent with the CARES Act. So that request has to be made consistent with the CARES Act. Their needs has to be consistent with the CARES Act, and that approval by the SLIB board needs to be consistent with the CARES Act. In no way, shape, or form am I suggesting we draft a letter that indicates otherwise. So I just want to provide that level of assurance. Concerning Senator Scott's concern about Medicaid reimbursement, I don't know that anyone, even a Medicaid costs and reimbursement or Medicare costs and reimbursement or any kind of federal expenditures associated with 2 hospitals within the same county, any of those concerns, I'm not sure if there's anyone in the country that can answer that question. That said, I would encourage that as part of this letter, that the Riverton Medical District, as part of its application, that those considerations be submitted to the SLID board, that to the best of its knowledge and through due diligence, there would be no harm as a result of that. In the alternative, that was my question presented earlier to the Riverton Medical District, to Dr. McGuffey, is if there had been any consideration of some type of an MOU that could be brought forth to ensure that no harm was occurred from federal reimbursements to either entity. To Senator Scott's point, the Riverton Medical District's going to go, right? So we're not in a position to prevent that from happening as a result of this letter of support. I just want to make that very clear that that's kind of a fallacious nexus that doesn't really exist in this letter of support. So with that, we have heard testimony today from a good part of the Wyoming legislature and that community regarding their impact from COVID, Fremont County being the heaviest impacted. How do we know what contributed to that? We don't fully know, but we do know they don't have a full serviceable hospital in the city of Riverton. And that despite their efforts over the past number of years, they haven't been able to solve that. And so they've now taken it upon themselves to do so, which is exactly what we want of our Wyoming citizens. They have a plan, they're moving forward, they're solving their own problems and providing healthcare to their community. We have a unique opportunity with $800 million of federal money. 800 million. This is one letter of support from the Corporations Committee for a county in crisis that needs hospital services. Just let's take it back to reality here. That's all it is, a letter of support. So I would ask for your favorable consideration of this letter to provide this service and this care to a community that is in desperate need of it, that is clearly impacted by COVID and is experiencing deaths even as recently as yesterday.
Thank you, Senator. I'm going to allow for any other comments, and then I've got a comment or two, and we're gonna vote on the motion. So, Mr. Co-Chairman, anything to add?
Oh yeah.
Okay. Committee, Senator, go ahead, Senator Case.
Oh, Mr. Chairman, thank you very much. You guys, it's a darn local fight. It doesn't make a lot of sense. I think Riverton's got a lot of points that deserve attention, but this is not our space. It's not our space to jump into a local kind of controversy. I'm willing to pledge to try to work this out. I think Riverton deserves their own facility, and I like to figure out how to do that. But I think that weighing into a very, very local fight it's not a good place for us, and I hope we'll avoid it. And I urge you to vote no, only with a commitment that these are serious concerns. Really, I think the best solution is for the Riverton organization to take over the Sage West facility in Riverton and provide their own services. It just makes the most sense to me. And I'd like to help them to do that. So with that, I hope we resist the motion and putting our thumb on the scale.
Committee, I'm just in full disclosure here. I'm not a Wolverine, but I was born at the Riverton Hospital. So, but I'm not going to declare a conflict because I think that's a long time. Things have come up this afternoon, and I intend to support not only this project, but many of the others that are talking about today.
Mr. Chairman, can you hear me?
Representative Cooper.
Yes, thank you, Mr. Chairman. Since I've been on corporations, much to my dismay, my experience, we jump into local issues. We've done it more than once. I just need to state that. But COVID CARE Acts, this is what this money is allocated for. Majority of the Northern Arapaho tribal members reside in and around the city of Riverton. That's important. A huge population, tribal population lives in and around close to Riverton. And so I just want to reiterate the fact there are going to be more deaths. There's more deaths because our Indian Health Service on the Wind River Reservation has historically been underfunded. So we've had a lack of quality of health care. It is good to see this group did their homework. And I feel loved that we're at the center of this. Fortunately, I'm going to tell you, there's going to be more deaths. How many more lives and blood have to suffer from COVID because of the underlying health conditions? The health disparities and the percentages are very high. It's a letter. This motion is a letter of support for this specific project to help its citizens of Wyoming. We have the tribes on board to help be a part of this solution going forward. And so I plead with you. It's a letter. It's a letter of support, and I ask for your support. Thank you.
All those in favor of the motion, please raise your hand. This way. Okay. I have four. Yes. Okay, that is. And Mr. or somebody else getting this kind of feedback. What is that?
Yeah, somebody needs to put themselves on mute, Mr. Chairman.
Who do we have who is not muted? Okay, that's better. Thank you. I'm sorry that I quit in the middle of those comments, but it was time to go to a vote for the motion. I will say this just to finish up. I'm very interested in supporting what we can over there in Fremont County. And I grew up over the hill in Sublette County, and I'm interested in supporting Sublette County. And I like the idea of whatever we can do in the northeast part of the state, where we heard testimony today that we have more bleed to the out-of-state hospital up there than perhaps any other place in the state. So we've got a lot of work to do in our hospital system. I'm going to do what I can to forward support on behalf of the Fremont County troops. I appreciate the words of Senator Case as well, because I think he's made some very good points. Hopefully that can be worked out. If it isn't, I'm going to do everything I can to support.
Mr. Chairman, can you repeat the results of the motion? Nobody could really understand what you were saying due to the feedback that was being experienced.
I counted 7 against and 4 in favor. And I would have voted to support the motion, and that would have made it 7-5. I did not see the hand of Representative Edwards, I don't believe. 7-5 is not the right number, but that's the count that I got. Okay. So committee, that brings us to the end of the agenda. I want to go to Ted real quickly. And Mr. Hewitt, can you provide for us any comments you have on the day or anything that we've got to take going forward or anything for the next meeting?
Thank you, Mr. Chairman. Just to summarize the committee's action over the meeting, you requested 7 bill drafts that we will put together in advance of the September meeting. You sponsored 1 bill draft to go to the 2021 session, and you sponsored 2 drafts for the next special session. And I do want to bring up the letter that leadership sent to all membership of the legislature this afternoon, notifying them that there won't be a special session at the end of June, or at least there is not currently scheduled a special session this month. And I just want to bring up, the idea of whether the committee wants to reconsider action on the bill draft to amend House Bill Senate File 1004, which has, timing issues in that the Business Council's programs over the next month or two are rolling out. So I just raise the issue of whether it makes sense to continue with that bill at this point.
Mr. Co-Chairman, that's a good point that Mr. Hewitt makes. By the time we go into a special session, which, by the way, may occur in late August or the first part of September, that's going to make that bill probably a moot point. So I wonder if we might not want to modify that bill request, Mr. Chairman, into a piece of communication directly to the Wyoming Business Council, for example. What are your thoughts on that?
Yeah, I think that's probably a better idea, Mr. Chairman, is to, so I guess I would make the motion to modify as you just directed, considering we won't be having a special session that soon. It might be the most effective methodology as it stands right now.
Okay, do I have a second to that motion so we can discuss for a moment? Representative Clem, thank you. So the motion on the floor is to pull the bill request from Mr. Hewitt's desk and turn it into a piece of communication to the Wyoming Business Council containing the same information that the bill would have contained. So Senator Scott, you've got a thought on that?
Yes, Mr. Chairman. I wonder if we wouldn't be in a stronger position to continue the bill, and then theoretically it would go to a next special session. I think we're likely to have one sometime in the September timeframe because we've got a set of budget problems. If it proves to be ineffective, there's any number of ways to sideline a bill at the time of the session. Quiet talk with the presiding officers, and it winds up in somebody's desk drawer. If it continues to be a live issue where a bill would be useful, then you have the committee on record and a bill ready to go. And that essentially allows the chairman some discretion to deal with the bill as to whether it really needs to come to the session or whether, if it does come to the session, it ought not to be heard as being moot. And if it isn't moot, if there's still a live issue there, and it would affect the funding, which in part would be operating funding for the remainder of the year, it might still be a useful tool. So I think it reinforces the letter to have that hanging there. So my instinct would be to leave things as they are right now, but that's a matter of tactics in trying to achieve the end we're all looking for. And if the chairman thinks that it's better not to have the bill hanging, that they might use an excuse to do nothing, then maybe we ought to deep six it.
A lot of wisdom there. Representative Air.
Thank you, Mr. Chairman. I apologize for being so slow here, but I missed what the issue was. Are we talking about the inclusion of the nonprofits in the 1004 bill?
That is exactly right.
Okay. That being the case, I thought we already said we were going to send a letter to the Wyoming Business Council as well as draft a bill. And I agree with Senator Scott. I think we need to do both.
Mr. Hewitt, am I misconstruing which bill you were referencing?
No, Mr. Chairman, that is correct. That is the bill that I was referencing. I just wanted to bring up for the committee's consideration the issue of timing with that bill, because yesterday we were working under the impression that a special session, could happen within the month of June, and now that is off the table. And so I just wanted to bring that up for the committee's consideration. I do have down that the LSO is to write a letter to encourage the Wyoming Business Council not to exclude nonprofits from the programs. And then the committee did sponsor the bill to explicitly direct the Wyoming Business Council to include nonprofits within their rules. So that's the current state. I just wanted to bring up the issue of timing for the committee.
Thank you, Mr. Hewitt. I want to go back to Representative Air. Thank you.
Thank you, Mr. Chairman. And again, if that being the case, I think we want to do both. We can have a bill draft in our back pocket in case it still is timely whenever the special session occurs. And we also have the letter already drafted and sent to the Wyoming Business Council encouraging that they include the nonprofits as well. So I want us to keep it like it is.
Representative Clem.
Thank you, Mr. Chairman. In light of the conversation, I'm inclined to leave things as they are as well. I think there's wisdom in having that bill out there. There's nothing to say that when that special session occurs, if it does in September or August, I highly suspect that the funds that we put towards those three programs will have run out. And so, and given that there'll be a balance of $900 million, I think we could direct more funding to those three programs if we so choose. And I think that this bill could be a vehicle for that, not only to direct funds to nonprofits, but also to refuel these other programs for our for-profits as well. So I'm inclined to leave things as they are. Thank you, Mr. Chairman.
So, Mr. Co-Chairman, the sentiment seems to be leaning toward just leaving things where they are. Do you have any inclination with regard to your motion?
Yeah, my second is bailed and I agree with him. I think let's keep steaming ahead the way that we are. I think Senator Scott's advice is really good.
Thank you, Mr. Co-Chair. So that motion is off the table then. Mr. Hewitt, thanks for allowing us to take the county road there for a minute, and we're back up on the highway. So please continue wrapping us up today.
Mr. Chairman, that's all I've got for you.
Okay, Mr. Co-Chairman.
Yeah, thank you, Mr. Chairman. My request is, because we did defeat that letter of support, my request is much like we had talked during the discussion, is to request that if it's feasible and possible for these folks to come to our next meeting, I think it would be great to have them and see if we can kind of track how this is going, and if we as the corporations committee need to jump in at that time, then we'll have that opportunity. So with your permission and the committee's permission, I'd like to keep this topic open and going forward on our agenda.
I happen to agree, Mr. Co-Chairman. I think, I want to make sure that we keep an ear to the ground and be prepared to support, if we're so inclined, some of these other projects that we've heard about today. And I can tell you this, all of the possibilities for renovation and for remodel and what we can do for our hospitals out across there. I know you'll be advocating for your parts of the world, and please do that. I think there's some real opportunity we're talking on our broadband task force. The co-chairman and I will meet on Tuesday as part of that group. We've brought up the idea of what can we do to enhance telehealth. That has turned into a little bit of a political football, unfortunately, but we're going to be tracking that too. So I hope you'll keep an ear to the ground on that front as well. The hospital network out there, I've got my concerns, and I hope we'll do everything we can in the next few months, because they absolutely, those hospitals took a beating. Final thoughts, Senator Scott.
Mr. Chairman, with regard to the hospital situation in Riverton, one thing I think all of us ought to be sensitive to, if Fremont County can work out a compromise amongst itself, and if they should need modification of any statutes to implement that compromise, I would hope they would be free to come to either this committee or to Committee 10, either one, possibly depending on the meeting schedules, to get sponsorship on such a thing. I think that if they could do it, that would be the best solution, because I'm afraid the road they're going down right now is going to give both of them the worst of all possible worlds. And a compromise, given the complexity of the federal reimbursement system and the way that dominates the economics, and given the problems of high fixed costs and volumes, it may take some creativity to get a compromise if they're inclined that way, and they might need some statutory relief. So I would hope both committees would be open to them if that need should arise.
I think I speak for this committee, given the sentiment today that we would favorably consider such a thing. But good points made, Senator Scott. Mr. Hewitt, I didn't mean to cut you short, but can you remind us what dates our next meeting is? Did you have that on your calendar in front of you there?
Yes, Mr. Chairman, it's currently scheduled for September 10th and 11th.
That's right. All three are the 10th and 11th, right? So the 10th and 11th of September is our next meeting. Members of the Corporations Committee, any final thoughts, any further thoughts on what we've done and heard the last 2 days? Really appreciate your work today. Thank you all. And thanks to those who visited with us this afternoon. Appreciate you all. We are adjourned.
Thank you, Mr. Chairman.
Thank you all.